that is benzodiazepines. Slowly we are coming into CNS now. Okay, so benzodiazepines are a class of anti-epileptics. It is a class of sedatives also. So basically what happens is, this is the presynaptic neuron and this are the postsynaptic receptors. Okay, so basically what happens is there will be presynaptic GABA, okay, which acts on this is a GABAergic neuron. So the action of this neuron is to decrease that is inhibitory signals, give inhibitory signals. Okay, so GABA is basically one which gives inhibitory signals. So this GABA acts on this GABA receptor, which is basically a chloride channel, and this GABA, these channels are activated. Okay, GABA receptor channels are activated, and it causes inhibitory effect. So it causes hyperpolarization, finally leading to neuronal inhibition and CNS depression. That is the effect of this GABA channels. So what does benzodiazepine do? This benzodiazepines, they bind to this GABA receptor and they'll facilitate GABA action. Okay, so this is the mechanism of action. They bind to GABA receptor between this alpha and gamma subunits. Okay, they facilitate GABA action, as a result of which there is increased chloride and there is hyperpolarization. That is, action potential will go into the negative and it will cause neuronal inhibition. So this is the basic mechanism what you need to remember. As a result of which it can be used for anxiety because you want to calm down the patient. It causes insomnia. It is used for seizure. It is used for treatment of muscle spasm, and it is used for treatment of alcohol withdrawal also. Okay, so according to the duration of action of this benzodiazepine, they can be classified as very short acting, intermediate acting, and long acting. In this you should remember a few things. Midazolam is short acting, lorazepam is intermediate acting, and diazepam and clonazepam are long acting. Just remember this much. Okay, nothing else. Now we need an antidote for this benzodiazepines, and that is flumazenil. Flumazenil is basically a competitive antagonist, means it sits on the same site where this benzodiazepines will sit, and it reverses the overdose. Okay, so if you go to pharmacology, pharmacokinetics part, there we had discussed competitive antagonism in detail. Okay, next. So main important thing is what alcohols do is, alcohols opiates, they also suppress CNS, right? So benzodiazepines also suppress CNS. So you should be very careful when you combine both. Second, you shouldn't suddenly stop because it can have a withdrawal effect. So it can cause abrupt withdrawal seizures, okay? Whenever benzodiazepines are given for control of seizures. Next, tolerance develops to sedative action more than anxiolysis, which means if you're giving benzodiazepines for a patient to have sedative effect, that tolerance will increase. Next time you'll have to use an increasing dose. But for anxiolytic, that is not the case. You can continue with the same dose for benzodiazepines. Next, lorazepam and oxazepam are safe in liver disease. How you remember this? This is the LOT rule. Okay, so lorazepam and oxazepam, they are safe in liver failure because most other benzodiazepines will be metabolized through liver. Midazolam is a drug of choice for induction. So whenever you want to send patient into like you want to sedate the you want to induce patient for AT tube insertion and all, that time the induction agent of choice is midazolam. Okay, next, clonazepam is preferred for myoclonic seizure. This actually is an anti-epileptic, clonazepam. Myoclonic seizure, especially your question will be based on SSP and juvenile myoclonic epilepsy. Okay, juvenile myoclonic epilepsy. Okay, in these cases we'll use clonazepam. Okay, next. Main important question in your pharmacology will be tapering gradually is required, or else it will cause rebound effects. Okay, next. See, benzodiazepines cause GABA potentiation, chloride influx, hyperpolarization, CNS inhibition. Okay, so I think prolonged frequency of chloride channel opening is done by benzodiazepine. Now what are barbiturates? Barbiturates will prolong the same action. Okay, so wherever benzodiazepines act on the same channel, barbiturates also act, but barbiturates will prolong opening of these channels and benzodiazepines will cause increased frequency of chloride channel opening. These are some minute wording changes which you should know. Okay, reversed by flumazenil, that is benzodiazepine. Barbiturate can't be reversed by flumazenil. Okay, I think we have discussed everything, so let's go to the questions. Yes, so drugs, which are the long-acting drugs? One is clonazepam and second is diazepam. Okay. Next, what is the antidote? Which is competitive antagonist? Flumazenil. Next, DASH is preferred in myoclonic seizures. Yes, very good. It is clonazepam. Next, safe in hepatic failure, the LOT drugs, that is lorazepam, and you will use oxazepam. Okay. Now we'll go to next question. Okay, so that is antipsychotics. Now again, typical and atypical antipsychotics are very commonly asked question. Okay, so we'll first go to typical antipsychotics so that we'll understand what typical antipsychotics are. Then we'll come to atypical antipsychotics. Okay, so these are basically antipsychotics. Mechanism of action is on dopaminergic neuron. We saw benzodiazepine is on GABAergic neurons, and here it is on dopaminergic neurons. So what happens is these neurons secrete dopamine. They act on this D2 receptors. Okay, so what does this typical antipsychotic drugs do? They'll block these receptors. Okay, as a result of which, what does dopamine do? Dopamine causes inhibition. Okay, dopamine causes stimulation. Okay, so for example, So basically dopamine is involved in control of movements. Okay, like in Parkinson, what happens? There is no dopamine receptors, there is no there's problem with dopamine pathway. So what happens is the patient is not able to control his movement. That controlling ability comes from dopamine. Okay, as a result of which you won't have control over your movements, and you will have tremors, rigidity, all these extrapyramidal symptoms occur because of D2 blockade. Now, among these typical antipsychotics, you should know that which has highest potency, strong D2 blockade, that is for flufenazine. Okay, so these are the questions. There are two drugs. One is haloperidol and flufenazine. Out of that, flufenazine is the most important drug, which has highest potency. Then comes haloperidol. Now these have more extrapyramidal side effects also because their potency is also higher and they have less sedation effect. Under low potency, that is weak T2 blockade, we have thioridazine and chlorthioridazen. Okay, so thioridazine is an example for low potency. High potency, we have flufenazine. Now, under systemic effects, so this is not only on the brain, on other effects, decreased dopamine causes control of psychosis, okay? And decreased dopamine actually causes what is increase in prolactin, because we discussed it a few minutes ago. I am not going to it again. Similarly, decreased dopamine will cause decreased nausea because of chemoreceptor trigger zone block. Basically, chemoreceptor trigger zone is a vomiting center in the brain. If the there dopamine is involved, if dopamine decreases, then it can also decrease nausea and vomiting, okay? So that also is controlled. Now, haloperidol is a drug of choice for acute psychosis. This is a very, very, very important question that is asked many times. So what is a drug of choice for acute psychosis? It's haloperidol. Remember, what is haloperidol? Haloperidol is a first generation antipsychotic which has a high potency also, along with flufenazine. Now, what are the things you need to remember? Whenever you are giving antipsychotics, you should note for neuroleptic malignant syndrome. So what is this neuroleptic malignant syndrome? Because of this antipsychotic administration, there can be fever, there can be increased creatine phosphate, there can be rigidity. These symptoms are pointing towards neuroleptic malignant syndrome. Second is acute dystonia that can develop during early therapy. And third is in long term, you'll get tardive dyskinesia. So these are basically symptom complex. These are extrapyramidal symptoms. Okay, so there are two things. In acute, you will get acute dystonia, and in chronic long term therapy, you'll get what is known as tardive dyskinesia. Okay. Now, there are some rare facts. These are actually asked in INICET. Thioridazine is known to cause retinal deposits, and it also causes QT prolongation. So you should use in moderation. So thioridazine can cause retinal deposits. That's why this retinal symbol, and you'll have QT prolongation also. And chlorpromazine, which causes corneal deposits and photosensitivity. So retinal, thioridazine. How do you remember? See R, thioridazine. Okay. Cornea, C for C, chlorpromazine. Okay. Next. Give anticholinergic. So whenever patient has extrapyramidal side effect because of this dopamine blockade, the drug of choice becomes anticholinergic. Okay, so trihexyphenidyl is a drug of choice for extrapyramidal symptoms. And if the symptoms are not tolerable, then we switch on to atypical antipsychotics. Okay, atypical antipsychotics don't have this effect. Next, so what does typical antipsychotics do? They cause D2 blockade, decreased dopamine, causes symptom control, but it has side effect, that is extrapyramidal symptoms and prolactin raised. Okay, I think I have explained everything. So let's go to the question session. So what is the mechanism of typical antipsychotics? It is pure D2 antagonism. Okay, nothing else. Pure D2 antagonism. Next, dash causes retinal deposits. I told you R for R, so it is thioridazine. Okay, thioridazine causes retinal deposits. Chlorpromazine causes corneal deposits. Okay, corneal deposits and photosensitivity. Dash is a drug of choice for acute psychosis. Very good. Yes, it's haloperidol. Next, dash in first days of therapy. What is used in what side effect is seen in initial days of therapy? Yes, it is acute dystonia. Okay, acute dystonia is seen in case of D2. That is typical antipsychotics. With long-term use, we have what is known as tardive dyskinesia. Okay, tardive dyskinesia. Drugs causing neuroleptic malignant syndrome is nothing but haloperidol. Haloperidol is the prototype drug. Basically, we have typical antipsychotics. Give dash anticholinergic. Okay, anticholinergic will give for extrapyramidal symptoms. Okay. Okay. Next, we'll go to second generation, that is atypical antipsychotic. So what is the difference here? So there we saw it was pure dopamine blockade only, but here there is extra, that is it also blocks a 5-HT2A, which are serotonin receptors. Okay, it blocks dopamine along with serotonin receptor, and as a result of this, I told you, whenever the dopamine and serotonin, they have inverse relation. So whenever dopamine is increased, serotonin is decreased. So what we are doing is we are maintaining a balance between two, so that when serotonin is also involved in serotonin receptors, that time dopamine is also under check, and that's why there is a better negative control symptom. That is, there are fewer extrapyramidal symptoms compared to first generation. Okay, so your answer for a mechanism of action of second generation antipsychotics will be 5-HT2A plus D2 antagonism. Okay, as a result of which we have less extrapyramidal symptoms. Now, which are the drugs which come under this? Clozapine. So whatever, anything which starts ends with pin. Okay, clozapine, olanzapine, quetiapine. Okay, and risperidone, ziprasidone. Okay, then we have aripiprazole. So all these are second generation. Now, what are positive symptoms and what are negative symptoms? That also you should know. So because these are antipsychotics, we will be covering again this in psychiatry. Positive symptoms means like hallucinations, something which was not there but still it is coming. Okay, hallucinations. Okay, like tactile hallucinations, auditory hallucinations. All those are positive symptoms. Negative symptoms are some function which is reduced, like there is no emotional effect. Okay, and lack of emotional well-being. So positive symptoms are something which is extra, like delusions, hallucinations, all those will come under positive. Negative is the patient has lost something like emotional touch, reduced speech output, mutism. Okay, all this comes under negative symptoms. So atypical antipsychotics, that is second generation, they treat both positive as well as negative symptoms. Okay, so risk of extrapyramidal symptom is minimal with atypical. It is more with typical antipsychotic. This must be clear by now. Okay. Now, with this one side effect of atypical antipsychotics, that is they can cause weight gain, they can also cause hyperglycemia, and they can alter your metabolic status. So we'll be monitoring this whenever you give atypical antipsychotics. So we'll be seeing in detail. Okay. So this clozapine is there, no? It causes something known as agranulocytosis. Agranulocytosis means there will be decreased neutrophils. Okay. There will be decreased granulocytes. So we'll be monitoring the CBC whenever you give clozapine. Second is it can also cause myocarditis, but I think you don't have to remember that. Just remember agranulocytosis. Next is olanzapine, which causes weight gain. See, the reason for this visual mnemonics, now you remember, no? See, this is O. Okay, olanzapine causes weight gain, metabolic syndrome. Okay, risperidone we have already discussed. It causes amenorrhea, it causes galactorrhea because of raised prolactin. That's why clozapine we do weekly CBC monitoring. Aripiprazole is a partial D2 agonist. Okay, so remember it is a second generation psychotic, okay, antipsychotic, but it instead of causing D2 antagonism, it causes partial D2 agonism also. Remember, that is aripiprazole. Next, risperidone causes increased prolactin, which we have discussed. So never abruptly stop this. Remember, never abruptly stop antipsychotics, never abruptly stop this one also, which benzodiazepines. Okay. Next, and anti-epileptics also. You never abruptly stop these things. So we have D2 plus 5-HT2A block causes balanced dopaminergic tone because we have decreased serotonin also. Less episodes of extrapyramidal symptoms. Now, which has least extrapyramidal symptom among all the drugs? It is clozapine. Remember, least extrapyramidal side effect is of clozapine. Which drug causes hyperprolactinemia? Maximum is risperidone. Third is drug for resistant schizophrenia. So initially you'll try with typical antipsychotics, but still the schizophrenia is not responding, then you'll go for clozapine. Okay, so clozapine is a good drug because it is used for resistant cases also. Episodes of extrapyramidal symptom is less, but it can cause what? Yes, it can cause agranulocytosis. So I think all these things I have discussed. We'll just go through the questions now. Mechanism of action is D2 inhibition along with 5-HT2A inhibition. Okay. Next, DASH causes agranulocytosis. Clozapine causes agranulocytosis. DASH is a partial D2 agonist, aripiprazole. Okay, aripiprazole is partial D2 agonist. What causes weight gain and metabolic syndrome? I told you, olanzapine. Okay, olanzapine. Next, least extrapyramidal side effect is for which drug? Yes, very good. It is clozapine. I told you, clozapine is a good drug. Drug for resistant schizophrenia again is what? Clozapine. If 5-HT2A blockade is there, then what is it? Yes, 5-HT2A blockade, then it is it is atypical antipsychotic. Okay, so that is the main difference between typical and atypical antipsychotic. Now you shouldn't forget this. Okay, now we'll move on to the next topic, that is antidepressants. So in this we have SSRIs, and then we'll have SNRIs, TCS. Okay, sorry. So SSRIs are selective serotonin reuptake inhibitors, which means you should basically remember that serotonin is a happy drug. Okay, so serotonin causes happiness. So you want to increase serotonin in the synaptic cleft. Okay, so that increased serotonin can act on serotonin receptors. So what will happen is whenever these serotonergic neurons, they will release the serotonin. They are reuptaken by this serotonin reuptake transporter, and because of which there will be less serotonin available here. Okay, so if we inhibit this, then automatically serotonin will be more here, and it will cause this happiness. Okay, so that is the mechanism of action of the serotonin reuptake inhibitors. So increased serotonin in synaptic cleft causes antidepressant and anxiolytic effects. So as clear as that. Okay, which are the drugs in this? You'll have to remember these few drugs. Okay? One is fluoxetine, second is sertraline, third is paroxetine, citalopram, escitalopram, and fluoxamine. These 6 are the most important drugs. Just remember 2 flus, okay, and citalo, okay, and sertraline. Paroxetine is less important. Okay, so very important is these antidepressants. They will take SSRIs will take 2 to 4 weeks for their onset of mechanism of onset of action. Okay, so it will have a delayed onset. Next, what are the broad indications? Depression, anxiety, PTSD, all these things. Okay, whichever is causing depression, it should be given. Okay, now it also causes mood stabilization along with acting on these parameters. What are the side effects? One is very important, is serotonin syndrome. Okay, so what is the serotonin syndrome? Whenever you combine SSRIs along with MAO inhibitors. So what are MAO inhibitors? MAO inhibitors are monoamine oxidase. Okay, So what happens is basically here what you're doing in by giving SSRIs, you are increasing serotonin in the synapse. Okay. Along with this, what will happen is the serotonin is actually broken down by this MAO enzyme. Okay, MAO B enzyme. Okay, sorry, MAO A enzyme. Okay, serotonin. So what happens is if you give this MAO inhibitors, they will prevent the breakdown of serotonin, and upon that you are also increasing serotonin in the synaptic cleft. So body will go into something where serotonin is too much in excess. Okay, so that is known as serotonin syndrome. So what happens in serotonin syndrome is there will be mental status changes, like there will be agitation, confusion, there will be hyperthermia, there will be tachycardia. Okay, there will be hyperreflexia. So all these symptoms will come under serotonin syndrome. Second is SSRIs can also cause sexual dysfunction. So because of the sexual dysfunction as a side effect, patient will have non-compliance to SSRIs, okay? And third is discontinuation syndrome. You are not supposed to stop serotonin uptake inhibitors abruptly, okay? This is most common to all CNS drugs. You can't stop anything abruptly. Now, few important things about specific drugs. Fluoxetine, okay? So here remember this battery, okay? Fluoxetine has the longest half-life. Second is paroxetine. I told you, you don't have to remember paroxetine because it can be teratogenic and it should be avoided in pregnancy. And third thing, fluoxamine, okay, not fluoxetine. Fluoxamine inhibits CYP enzyme synthesis. This is not frequently asked, but somewhere rarely in INICET this can be asked. So always start SSRIs at a low dose and then we'll titrate. So after every like 2 to 3 weeks, we'll be upgrading the dose of SSRIs. So one important thing is you'll have to monitor for suicidal tendencies. This is increased in case of SSRIs. It can have rebound effect also. And along with that, you'll be not abruptly stopping. Every SSRI will be continuing up till like 6 to 9 months or 1 year. You don't stop it abruptly. So SSRIs cause reuptake inhibition. It increases serotonin and it causes mood stabilization also. Okay. So most activating SSRI, I told you, most longest half-life and most activating is fluoxetine. Safest in cardiac disease is sertraline. Okay, this is one more question that can be asked. Safest antidepressant in cardiac disease is sertraline, and adverse effect is sexual dysfunction. Paroxetine, pregnancy problem, PPP. Okay, paroxetine is for pregnancy problem. Okay, so serotonin syndrome is all yes. Okay, fever, agitation, rigidity, and all. Okay, so now we'll go to the questions. Onset, how much delay does it make? It takes around 2 to 4 weeks for the drug onset to happen. Next, dash has longest half-life. Yes, it is fluoxetine, and it is the most activating drug also. Okay, most potent. So fluoxetine. Next, which has a teratogenic effect, avoid in pregnancy? Paroxetine. That's why don't remember paroxetine. Next, dash inhibits CYP enzymes. Yes, it is fluoxamine. Fluoxamine. Next, SSRI safe in cardiac diseases? Sertraline. Next, in serotonin syndrome, you don't combine what? You don't combine MAO inhibitors along with this. Okay. So next we'll go to tricyclic antidepressants. Remember where we had seen tricyclic antidepressants? Yes, very good. When we had seen atropine toxicity versus amitriptyline toxicity. If you remember, I think it was topic number 12, right? In that topic, we had gone through atropine versus amitriptyline. Okay. Yes. So now first thing is we'll see how this tricyclic antidepressants act. So here mechanism of action is dual. Okay, one is this TCS, they'll block this uptake of norepinephrine, and second it will block the uptake of serotonin. So this mechanism was correct. Okay, but along with that we have norepinephrine uptake inhibition also. Okay, so we have more monoamines. What are monoamines? Serotonin is a monoamine, dopamine is a monoamine. Okay, epinephrine is a monoamine. All these are monoamines. Okay, so we have increased monoamines, and because of increased monoamines we'll have mood elevation and antidepressant effect. So what is the action of TCA, tricyclic antidepressants? It is basically along with the 5-HT reuptake inhibition, we also have yes, very good, norepinephrine reuptake inhibition also. Now along with this, there is one more action, that is it also inhibits, okay, this TCS also inhibits cholinergic channels. Okay, so it has anticholinergic property also, and this is the reason why we have anticholinergic side effects along with the anti-TCS, that is tricyclic antidepressants. Now which are the drugs you need to remember? One, remember amitriptyline, okay, and imipramine. These two are more than enough. Okay, imipramine and amitriptyline. So what are the additional actions? Anticholinergic, I told you, whatever was done by atropine is done by these drugs also. Second is antihistaminic also, and third is alpha-1 block. Basically you have remember no, like alpha-1 block we had studied along with sympathetic system. Okay, alpha-1 block causes low BP and it can also cause dizziness. Okay, so these three additional actions are also there for this tricyclic antidepressants. Now what are the indications? Again, it is antidepressant, so it is used for depression. Second is you would have seen amitriptyline being given for neuropathic pain like sciatica, or there is some vertebral issues, okay, where there is impingement of the nerve. There we give amitriptyline because it can be used for neuropathic pain. Next, third is enuresis. Okay, so imipenem. Okay, imipenem is a drug which we give for nocturnal enuresis. Okay, imipenem. And then we have for OCD we give clomipram, but I don't think you'll have to remember this. Just remember these three indications. Now, in elderly, this is elderly it is preferred because these other antidepressants have more sedation action, but these TCS have least sedative action. That's why it's preferred in elderly. Okay, so basically nortriptyline is preferred. Next, what are the 3 C's of toxicity? Toxicity of amitriptyline? Yes, very good. One is coma, which is coma. Second is convulsions. I told you convulsions don't occur with, yes, it doesn't occur with atropine. It occurs with the TCS. And third is cardiotoxicity. I told you again and again, QT prolongation. So what is QT prolongation? QT prolongation is more than 100 milliseconds of QRS complex. That occurs along with this TCS, but this never occurs with atropine. Atropine, what happens? QT prolongation doesn't occur. There, what happens is there occurs tachycardia. Okay, tachycardia occurs in atropine, but in TCA toxicity, QT prolongation occurs. Now, again, this is a type of serotonin reuptake inhibitor, right? There is that mechanism. So that's why this should be avoided along with MAO inhibitors. Now, in lethal doses, it can cause arrhythmia because of QT prolongation. So I think I have explained all this. For nocturnal enuresis, we use imipenem, and for OCD, we use clomipram. C for C, okay? And then fatal overdose can occur. So now, tell me, what is the antidote of choice? Remember, yes, very good. Remember, you had studied this in atropine toxicity also. We compared atropine versus amitriptyline toxicity. Yes, what is the drug of choice? What is the antidote for TCA toxicity? Yes, very good. It is sodium bicarbonate. Okay. What was the antidote for atropine toxicity? Yes, it was physiostigmine. That's why I told you, both have similar anticholinergic syndromes, that is symptoms. But what differentiates? Yes, it is QT prolongation. QT prolongation is the only thing that differentiates both these things. It should be helpful for you in MCQ also. Now, mechanism. What is the mechanism of action? One is norepinephrine reuptake inhibition, and second is serotonin reuptake inhibition. Okay. Next, dash is the most potent for OCD. I told you. C for chlor. What is that? Chlomipramine. Okay. It's very difficult to remember names. Clomipramine. Okay. Clomipramine. Next, 3 C's of toxicity, coma, convulsion, and one more is cardiotoxicity. Next, drug of choice for nocturnal enuresis is imipenem. Next, yes, that's it. Now we'll go to next topic, that is lithium. Okay, so we are basically going towards mood disorders now. So where does lithium act? Lithium's mechanism is a little bit different. If you remember, do you remember where there was one more GQ coupled receptor along with IP3 DAG pathway? Yes, remember. Just now, few minutes ago we had discussed. Yes, this was for oxytocin. Okay, so whatever mechanism of action oxytocin has, similar mechanism this also has, because it is GQCR coupled receptor. Okay, so we have IP3 DAG pathway here, but where lithium acts is from IP3 to, for this pathway, inocetyl monophosphatase enzyme is required. Okay, inocetyl monophosphatase, this is inhibited by this lithium. Okay, as a result of which there is no excitability, decreased neuronal excitability, so there is mood stabilization. So basically we want to stabilize the mood. Okay, so your answer for the question is, what is the mechanism of action of lithium? It is inhibition of inositol monophosphatase. Now, what is the primary indication of lithium? Lithium is mainly indicated in bipolar disorder, okay, BPD, mania, and in maintenance phase also. Next, what is important for lithium? We have seen this before also. What is important is therapeutic monitoring. It's an important drug which comes under therapeutic drug monitoring. So we don't want levels to be very high. We don't want it to be very, very low also. So toxic dose is when it goes more than 1.5 milliequivalents per liter, and between 1.6 to 1.2 only will get therapeutic action. Excretion of lithium is mainly via renal excretion. Do you remember one more indication where we discussed lithium? We discussed in renals actually. Yes, very good. It is in nephrogenic diabetes insipidus. I told you diabetes insipidus can be of 3 types. One is psychogenic, okay, where patient drinks a lot of water. Second is central diabetes insipidus, where the lesion is in the brain. And third is peripheral. Peripheral we also know call it as nephrogenic diabetes insipidus. In this nephrogenic diabetes insipidus, we give lithium. Okay, so lithium causes nephrogenic diabetes insipidus. Lithium causes nephrogenic diabetes insipidus. I'm very sorry. Lithium causes nephrogenic diabetes insipidus. And for this side effect, which is a drug of choice, that is amiloride. That is what we discussed in renals. Okay, so lithium induced nephrogenic diabetes insipidus. Okay, the drug of choice is amiloride. Okay, that is how we connect things. Okay, that is what is called integration. Now, in with help of lithium, we have decreased suicidal risk also. And one more thing is lithium. Okay, so it has it interferes with synthesis of thyroid hormones, so it has hypothyroidism as a side effect also. So what are the 2 side effects of lithium? One is hypothyroidism, okay, hypothyroidism, and second is nephrogenic diabetes insipidus. Okay, so NSAIDs, ACE inhibitors, and thiazides will actually increase lithium toxicity. That is because these drugs prevent excretion of lithium. Okay, so you shouldn't give NSAIDs, ACE inhibitors, and thiazides along with lithium. Second is lithium can cause Epstein anomaly. Okay, Epstein anomaly. So what is Epstein anomaly? It is a type of congenital cyanotic heart disease. Third is lithium toxicity. What are the symptoms? Tremors, ataxia, confusion, seizures. So these are basically CNS symptoms. So that means you will have to see for therapeutic drug monitoring. So you will have to monitor renal function also, and you'll have to monitor thyroid function because it can cause hypothyroidism. Avoid dehydration and maintain salt balance. And third is amiloride reverses lithium-induced diabetes insipidus. That is what we discussed. So all these things I think I have discussed. Okay. Okay. So we'll go to the question. Okay. Yes. Inhibits which enzyme? It inhibits inositol monophosphatase. Second, therapeutic range is toxic levels is more than 1.5 milliequivalents per liter. Causes DASH because of ADH antagonism. Yes, it causes nephrogenic diabetes insipidus. Interferes with thyroid hormone synthesis, hence it causes hypothyroidism, and you should monitor for thyroid levels. Okay, monitor T3, T4, TSH. Contraindicated in pregnancy because of what? Epstein anomaly. Drug of choice for acute mania is, yes, very good, that is lithium. There's one more drug which you give in acute mania, which you had seen earlier, that is haloperidol. Haloperidol also. Okay. Next, DASH reverses lithium-induced diabetes insipidus, amiloride. So if you go to your GTs, you'll see similar type of questions only are repeated. Okay, that's why we have these one-liners. Next we'll go to anti-epileptics. Okay, so we'll go to anti-epileptics, one more important topic in CNS. So there are various classes of anti-epileptics, and where students commit most of the mistake is understanding their mechanism. Okay, so basically we have 2 to 3 different mechanisms of anti-epileptics. See, this is the presynaptic neuron. In epilepsy, what happens is there is increased discharge. Okay, so we want to decrease that discharge that is happening in the postsynaptic neurons. Okay, between these transmissions. So what happens in postsynaptic neuron is there can be excitation and there can be inhibition. Inhibition is basically by GABA. So GABA enhancers like benzodiazepines, phenobarbitons, they will prevent seizures. As simple as that. Second is there will be some excitation channels. Okay, for example, sodium channels, they actually cause excitation. Glutamate channels cause excitation. So blocking of these excitation channels again suppress seizures. So either you decrease excitation or you increase inhibition. These both are different mechanisms. Now there is something called a synaptic vesicle protein also, SV2 vesicle. This also actually increases inhibition. So whichever are SV2A binders, they will increase excitation and they will cause a decreased frequency of seizures. Okay, so main mechanism is either blocking of sodium or T-type calcium channels. This actually prevents seizures. Okay, this is based on the inhibition part. So we'll see different groups of drugs. So first is sodium channel blockers. So sodium channel blockers, they block the sodium channels and they stabilize sodium channels. So examples are phenytoin, carbamazepine, and lamotrigine. Okay, so these are like first line anti-seizure drugs, except lamotrigine. These two, phenytoin, carbamazepine, we use in many cases. Phenytoin is used for generalized seizure, GTCS type of seizures, and carbamazepine is used in localized seizure, that is focal seizures. Okay. Now, T-type calcium channel blockers are ethosuximide, T4T, and valproate. Okay. Now, important thing in this is valproate has all 3 mechanisms of action. It has GABA facilitating action, it has T-type blocking also, and it has sodium channel blocking also. So if you want one anti-epileptic which can be given in any type of seizure, that is actually valproate. There are specific contraindications also for valproate. We'll be discussing it. Okay, so valproate can be given in almost every type of seizure because it has multiple mechanism of action. Okay, so it will be useful for sodium channel blockade, calcium channel blockade also. Calcium channel blockade, ethosuximide is the drug of choice actually, but it is not available in India widely. That way again valproate is only used. So what happens is this T-type of channel blockers are mainly involved in the thalamus area. So it will decrease thalamic pacemaker activity. Okay, so this was once asked in INICET earlier. Okay, so this is used in specific absence type of seizures. Okay, so valproate is a drug of choice for absence seizures. Now GABA potentiators are benzodiazepines, barbiturate, and valproate, and there is one more known as vigabatrin. Vigabatrin is there is already GABA. Okay, so GABA inhibitor. Okay, so it is GABA inhibitor. Okay, so it increases the inhibitory tone. Okay, so vigabatrin, valproate, barbiturates, and benzodiazepines. Now, in addition to this, there are 2 more mechanisms very important. One is glutamate blockers. Okay, glutamate is excitatory, and the same glutamate molecule is also involved during hepatic encephalopathy. That is the reason behind hepatic NCAF. Okay, so here what it does is it decreases excitatory transmission, and example is this mates. Okay, topiramate and felbamate. So glutamate, you are seeing this now. Glutamate, topiramate, felbamate. Now there is one more decreased vesicle release, that is sp2a inhibitors. Okay, so this is actually levetiracetam. Okay, so we'll see some specific side effects of these drugs. First is phenytoin and valproate. They are both teratogenic. Okay, phenytoin causes fetal hydantoin syndrome. Okay, fetal hydantoin syndrome, and valproate is known to cause neural tube defects. Okay, next, carbamazepine is actually an autoenzyme inducer, which means Carbamazepine induces enzymes which causes metabolism of the same drug. Okay, so carbamazepine is an enzyme inducer, which is auto-inducer. And also carbamazepine is involved in SIADH and SJS, that is Stevens-Johnson syndrome. Never ever taper anti-epileptics abruptly. Next, levetiracetam acts via SV2A protein. This is the very unique action. Okay, there are two drugs which have very unique action. One is this levetiracetam, and second is this glutamate blockers, topiramate and felbamate. Rest all are like channel blockers. These both are like little bit different. So topiramate, in addition to glutamate blockade, also has weak carbonic anhydrase inhibition. Also, we will not go much into depth. Okay, now. We have to monitor levels for toxicity, because most of these anti-epileptics, especially phenytoin and all, have narrow therapeutic drug monitoring. If you remember phenytoin was involved in both zero order kinetics and first order kinetics. So it was involved in both. So we know that at lower doses it was first order kinetics, at higher doses it became zero order kinetics. So toxicity levels are toxicity chances are higher. So that's why we do therapeutic drug monitoring. Okay. So what is the mechanism of action? Ion channel or neurotransmitter modulation causes decreased neuronal firing, causes seizure control. So drug of choice for GTCS, I told you, is valproate. Second, drug of choice for partial seizures is carbamazepine, and drug of choice for absence seizures is ethosuximide. Okay, I think I have covered everything. We'll solve questions. So sodium channel blockers. Which are the sodium channel blockers? Yes, very good. They are valproate, phenytoin, carbamazepine. Next, what are the T-type channel blockers? Ethosuximide and valproate. These are used for absence seizures. Okay, absence. Glutamate blockers are felbamate and topiramate. Yes, levetiracetam is SV2A binder. Okay, it decreases vesicle release. Next, topiramate has weak carbonic anhydrase inhibition. Dash causes neural tube defects. Valproate. Yes, so we'll go to next topic, that is carbamazepine now. So carbamazepine we'll see in depth. So carbamazepine is basically a sodium channel blocker, which we have already seen. So decreased sodium, so there is decreased firing of neurons, so that actually controls seizures. So this is used for partial seizure, that is focal seizures. Earlier we were using the term as partial seizure. Nowadays we use focal seizures. Okay. It is also the drug of choice for something known as trigeminal neuralgia. Okay, so trigeminal neuralgia, drug of choice is carbamazepine. It is also used in bipolar disorder, but bipolar disorder drug of choice is lithium. Okay. Now, what is the metabolism? I told you it is an autoenzyme inducer. I have already explained what it is. Now, what are the side effects? I told you SIADH. SIADH will cause hyponatremia. Second is there is risk of Stevens-Johnson syndrome. Third is it can cause aplastic anemia, ataxia, and diplopia. So these are the side effects of carbamazepine that you need to remember. Just see the images and you'll automatically remember. So there's one side effect of carbamazepine, that is it should never be used for absence seizures and myoclonic seizures. It should be only used in focal seizures or generalized tonic-clonic type of seizures. It should never be used in absence and myoclonic seizures because it will worsen absence and myoclonic seizures. Okay. Now, next, what are some questions which you should be very worried about? One is avoid combination of carbamazepine along with MAO inhibitors and lithium, because these can actually increase the risk, okay, of MAO inhibitors and lithium. The second is it will reduce, because I told you it induces enzymes. So it also induces enzyme CYP3A4, which is also useful for your OCP breakdown. So as a result of which, I told you when we were discussing OCP that certain enzyme inducers like anti-epileptics, carbamazepine is one of the examples. Okay. Next, worse absence pattern. That is, if you use carbamazepine for absence seizures, it will actually worsen it. Okay. Now, very important question which has been asked many times is which specific HLA mutation causes this SJS syndrome. So, those people who receive carbamazepine and have this specific mutation, that is HLA-B1502, they are at higher risk of developing Stevens-Johnson syndrome. And hence, before starting carbamazepine, actually, ideally, you should do HLA-B1502 levels, or else patient will develop Stevens-Johnson syndrome. Now, it can also cause aplastic anemia and also can cause leukopenia, that is decreased WBC. That's why you'll have to monitor CBC in every patient who is receiving carbamazepine. And it can also stabilize mood. That's why it's also used in bipolar disorder. Okay, so you should monitor two things. One is CBC, another is sodium. Sodium is for SIADH, because in SIADH you'll also get hyponatremia. Okay. Okay, fine. So I think I have gone through everything. Okay, let's answer the questions. Mechanism of action is what? Sodium channel blockade. There shouldn't be any confusion. Uses focal GTCS, bipolar. It is drug of choice for one more thing, that is, it is drug of choice for trigeminal neuralgia. Okay, trigeminal neuralgia. Next, adverse effects, hyponatremia is because of SIADH. Contraindication is absence and myoclonic seizures. It can actually worsen. These seizures. HLA-B1502 is known to cause risk of SJS. Okay. Reduces DASH efficacy, it reduces OCP efficacy. Okay, and drug of choice for trigeminal neuralgia is carbamazepine. I think I have covered everything. Okay, so we'll go to the next anti-epileptic, that is valproate. Now, valproate is very commonly used anti-epileptic. We use in and out valproate, so you should definitely know this. So we'll go to the image first. So what happens is valproate has multiple mechanisms of action. I told you. First is it blocks the sodium channels. Second, it blocks this T type of transient type. Okay, L type is long type, T is transient type. T type of calcium channels, and it also increases GABA. Okay, it increases GABA enzyme synthesis. So it acts via 3 mechanisms. So final achievement is it decreases neuronal excitability. Since it has many mechanisms of action, it can be used for wide spectrum. So it can be used for GTCS, it can be used for myoclonic seizures, it is a drug of choice for absence seizures, it is also used in bipolar disorder, and it is also used for migraine prophylaxis. So valproate is one drug which will definitely come in your INICET exam, because NIMHANS prepares your INICET psychiatric questions. Okay. Now, what are the side effects of valproate is more important than what is the mechanism of action of valproate. One is hepatotoxicity. I personally have seen many people, many patients, especially pediatric, who were started on valproate and developed hepatotoxicity. So hepatotoxicity along with pancreatitis, okay, these two are known complications of valproate. Second is weight gain. Third is tremors. All these are CNS effects, okay, tremors, neural tube defects, alopecia. There's a famous mnemonic of valproate, that is valproate itself, okay. So you can go back and see this mnemonic under Google image. But we are concerned about 2 main side effects. One is hepatotoxicity and second is neural tube defects. Now, since it is a teratogenic agent, it can cause spina bifida, that is neural tube defect. It can cause liver disease also. And it can cause fatal hepatic failure if used in children less than 2 years, especially those who have some inborn error of metabolism where valproate couldn't be metabolized, because valproate mainly requires hepatic conjugation and all. No? So if hepatic excretion is not there, then valproate can cause hepatic failure in those hepatotoxicity also. So that's why in less than 2 years, we don't use valproate, okay? Unless there is a very definite indication that we have to use. Now, enzyme and metabolization thing is this valproate, it will increase lamotrigine toxicity because of this enzyme inhibition. Okay, so valproate inhibits the enzymes which metabolizes lamotrigine. So when we give combination of anti-epileptic drugs, so when lamotrigine is given, valproate can increase lamotrigine toxicity. So we will have to give lamotrigine at a lower dose. So avoid enzyme inducers. Okay, I think you understood the point. Now next thing, valproate. You will get a question like a patient was started on valproate and then he lands in hyperammonemia, that is hepatic encephalopathy. The reason would be valproate because of liver failure. Okay. Second, valproate also has platelet dysfunction. Okay, so that's why it can cause delayed clotting time, that is the patient can present with bleeding. And third is it is the drug of choice in juvenile myoclonic epilepsy. I told you already. For absence and myoclonic epilepsy, we use valproate. So very important, whenever a patient is on valproate, always monitor LFTs. Okay. And second is always see whether the woman, especially of reproductive age group, you should avoid valproate because it can do 2 things. One is it can cause weight gain, which becomes a problem for cosmetic issues, and second is teratogenicity risk. Okay. So drug of choice of myoclonic epilepsy is valproate, multi-target mechanism of action, and it causes neural tube defect. All see here there is mnemonic. Okay. So yes, very good. So here there is a mnemonic. So valproate, it has versatile volume, that is weight gain, alopecia, ammonia, and absence issues. It is used. Ammonia is nothing but hyperammonemia because of liver failure. Third is liver toxicity, lamotrigine interaction. P is pregnancy, okay, and platelet dysfunction. R is round of weight, okay. O is like others like tremor, migraines. Then A, it is used for all seizures. Everything I have explained, okay. It's an enzyme inhibitor, not an enzyme inducer. We had carbamazepine and phenytoin, which were enzyme inducers, okay. It stimulates other enzymes. Valproate actually inhibits other enzymes. That's why we have lamotrigine toxicity and not lamotrigine failure, okay. All these points I had clearly explained in my first video. First part, that is pharmacokinetics. So we'll go to the question. So valproate increases GABA plus blocks which channels? It will block sodium plus T type of calcium channels also. Next, causes dash, it causes hepatic encephalopathy. It is hepatotoxic. Useful in what? It is useful in myoclonic epilepsy, and it is useful in absence seizures. Okay, and it is also useful in bipolar disorder. It is useful in migraine prophylaxis, and it is useful in GTCS also. Fatal. What it causes fatal hepatic failure if used in less than 2 years. Now, drug of choice for myoclonic epilepsy is valproate. Remember, these things are the ones where you should never do any mistakes. If weight gain plus tremor is there, then think of valproate. These are both side effects. Monitor what regularly? Monitor CBC, because you don't want the patient to go into leukopenia. Okay, you don't want the patient to go into thrombocytopenia and all. Okay. I had actually once seen a case of valproate causing thrombocytopenia. I have seen that also. Valproate causing megaloblastic anemia I have seen. So valproate is such a wonderful drug when it comes to side effects. Okay, and you have to monitor LFT regularly. Okay, hepatotoxicity. Yes. So we'll go to next, that is phenytoin. Okay, these anti-epileptics are that important. That's why I'm focusing each and every point on anti-epileptics. So next, going to phenytoin, we know the sodium channel blocker, there were 3 main subcategories. One was carbamazepine, second was phenytoin, and third was valproate. Okay, this is what you need to remember. Now, one more was lamotrigine actually. We'll come to it later on. So voltage gated sodium channels are deactivated by this are deactivated by phenytoin. So as a result of which we have decreased excitation. Okay. Now, it is used mainly for GTCS. For partial means focal seizures. Earlier we used to have, but now we are not using much. And main thing, it is used in status epilepticus. If you see status epilepticus protocol, okay, that is given in your, it will be given in your medicine, and it won't be given in your pharmacology and all. It will be given in your KD party. Okay, so in that you'll see pheneton is still the first drug which we give. Okay, pheneton and then phospheniton. So for status epilepticus, we still use it as a first line drug. Okay, so now I told you valproate is a CYP inhibitor, but here pheneton is a CYP inducer. As a result of which this will cause OCP failure. Before also you had one more drug which caused OCP failure, carbamazepine. Yes, very good. So in your options, whenever you have OCP failure, you will have carbamazepine, you will either have carbamazepine or you will have pheneton, and along with that you will have valproate. So remember, you will never mark valproate. Okay. Now pheneton, I already told this point, zero order kinetics, we have discussed in chapter number 1, okay, topic number 1. Now side effects of pheneton is again remembered by Hot Malik. I think the mnemonic is more famous than pheneton in itself. Okay. I don't want to go into detail, but I want you to focus on few important side effects. One is gingival hyperplasia, which you definitely remember. Second is hirsutism. Third is megaloblastic anemia because of folate deficiency and fetal hydantoin syndrome. Okay, and along with that CNS we have nystagmus. Just remember this. I think you already know this. Teratogenic, it causes fetal hydantoin syndrome. Okay, and do not mix with dextrose. Yes, we don't mix it with anything else. We just give it plainly. Okay, why specifically dextrose? Yes, because what happens is sometimes patient comes and we'll give antiepileptics. Okay, and then we'll measure blood glucose levels, and that time it will be like blood glucose levels will be less. Okay, so what people will do is they'll give antiepileptics also and they'll give dextrose also together. Okay, so that is to be avoided. Second thing is especially the nursing staff who give administered drugs, they usually administer either in D5 or in normal saline. So it has become a common trend. So some they should know actually, but sometimes mistakes happen and they give in dextrose. So pheneton we never given dextrose. And third is pheneton is never given rapid, it is given over 20 minutes, because if you give rapid, what will happen is it will precipitate arrhythmia, it will cause hypotension also. So one rare side effect of pheneton is if you give IV pheneton, it can lead to something known as purple glove syndrome. Okay, purple glove. There was one more thing which was similar to this, that is warfarin skin necrosis. Okay, warfarin skin necrosis. It was a little bit different, but this is purple glove syndrome. Okay, this is with pheneton. Now pheneton also interferes with absorption of vitamin D, hence it causes osteomalacia and it causes decreased absorption of folate. All these things I have discussed already. We'll go to the questions. What is the mechanism? Sodium channel inactivation. Second, dash order at high dose. At high dose, it is first order. Okay, sorry, at high dose it is zero order. At low dose it is first order. First it comes low dose as first order, and then enzymes get saturated, then it goes into zero order. Okay. Next, metabolism CYP inducer. That's why it decreases OCP efficacy. Dash syndrome it causes. Yes, it causes purple glove syndrome. Vitamin D decrease causes what? It causes osteomalacia. It inhibits what absorption? It inhibits folate absorption. Next, drugs causing gingival hyperplasia is pheneton. Next, fetal anomaly. What anomaly we get? Fetal hydantoin syndrome. Okay. Yes, we'll go to next antiepileptic now. That is, sorry, we are finished with antiepileptics. Now we'll go to opioids. Again, a very confusing topic, and we'll make it very easy for you. Okay. Opioids is a very confusing topic. Okay, so we'll go through it in depth now. So basically everything is about opioid receptors. Okay, nothing else. I think if you realize what is opioid receptor, then it is very easy. So basically what happens is whenever there is an opioid agonist, it sits on this receptor, which is basically GICR, okay, not GQCR or GPCR as we had seen earlier. It will activate adenyl cyclase, and then that it will inhibit adenyl cyclase, and because it is inhibited, right? So opioid is something which inhibits things, you know, right? Like opioid overdose, something is inhibited, respiratory depression occurs. So it's just like these benzodiazepines and barbiturates where they decrease the effect, okay? So they inhibit adenyl cyclase, CAMP is decreased, as a result of which this decreased CAMP, we saw in oxytocin that increased CAMP causes increased calcium entry, and then there is uterine muscle contraction. Here it is ulta, okay, that is decreased CAMP causes decreased calcium entry, and as a result of decreased calcium entry, there is no release of neurotransmitter, okay. Along with that, there is increased potassium efflux. So what will happen is neurotransmitters should have been released, but these neurotransmitters are not released, as a result of which we get various effects. These effects can be like analgesia, sedation, euphoria. All these are like balance of these receptors. So what should be your answer for your MCQ? One is GI protein mediated, GICR. Second is decreased CAMP and mu receptor agonism. Okay, so these three are the words that you should look for, because this GICR can be of mu, kappa or delta type. Okay. Now, which are the various drugs you have? Now, again in this, you will have a lot of questions. So the strongest one among everything, okay, is the one which is often referred in movies, that is morphine. So you would have noted that people actually are behind morphine. Okay, so morphine is the strongest one. Along with fentanyl, fentanyl is also strong, but it is short acting. So fentanyl, morphine, both are like illegal ones. Now, we'll give something to counteract this morphine and fentanyl, that is opioid addiction, and that is methadone. You would have heard of methadone patches and all. So when methadone is applied, it will act for a long time and it will cause desensitization of the receptors. Okay, so it is like a de-addiction drug. So methadone is a long acting. It is a replacement for morphine and fentanyl over addiction. Okay. Now, what is buprenorphine? Buprenorphine is a partial agonist only, means it will not do all effects brought about by morphine, but it will do only some of the effects. Codeine, which is a popular cough suppressant, it is also a weak opioid, and tramadol is also a weak opioid. Along with it has SNRI action. SNRI means selective norepinephrine reuptake inhibitor. So what are the uses of opioids? It's easy. So first is analgesia. For any painful procedure, we'll use morphine. It can be used as anesthesia adjunct. It is used as cough suppressant, and it is used as antidiarrheal, that is loperamide. Loperamide is opioid agonist, which is used for treating diarrhea. So with these uses only, you will come to know what are the side effects. Okay, so what are the adverse effects? One is respiratory depression. This is the most lethal. You have seen in movies, no? Morphine injection, and then they go into respiratory depression and die. So respiratory depression is the most dreaded side effect. It causes meiosis, that is pinpoint pupils. Can you remember of one more condition where pinpoint pupils had happened? Yes, very good. In parasympathetic poisoning, in OP poisoning, you say, in OP poisoning, you will have pinpoint pupils. Next, constipation. Okay, constipation and urinary retention, as a result of which we have this anti-diarrheal effect of loperamide. Okay, that is how you remember things. Constipation occurs and urinary retention because it relaxes the bladder muscles. Now, what is the triad of opioid intoxication which you should look in your MCQs? One is meiosis, I told you. Second is respiratory depression. Third is coma. This triad, if you see, remember, it is acute opioid intoxication. Reversal agent is naloxone. So naloxone actually inhibits. It's the antidote of choice, and it has very short half-life. So immediately you give naloxone injection, patient will like come out of that respiratory depression. You have seen it in movies also. Now, what are the withdrawal effects? Withdrawal symptoms means if you give again that same dose, the symptoms will go away. And these are exactly opposite to opioid symptoms. That is, one is lacrimation. Second is yawning. Okay, that means that is pointing towards like you need one more dose. Third is diarrhea, rhinorrhea, increased secretions. Okay, piloerection, that is erection of the hairs. So all these are withdrawal effects. So withdrawal symptoms will also come in your exam. So a patient coming with excessive lacrimation, yawning, he has diarrhea and rhinorrhea. So what is the drug of choice? Okay, so that time you give agents which like methadone, you give buprenorphine to counteract those effects. Okay, because you don't want to get whole effect, you want to get only partial effect. Now remember, never combine it with MAO inhibitors, because these also can also cause serotonin syndrome. Which are the other drugs which cause serotonin syndrome? SSRI, SNRI, and we had one more TCA. Okay, these three also cause the serotonin syndrome. And methadone is the longest acting. It is used for de-addiction. Buprenorphine is partial mu agonist. Okay, I think I have explained everything. Okay, now yes, we'll go to the questions. These are basic things that you need to know. Okay, so mechanism of action. So it is dash receptor agonist. It is mu receptor agonist. Next, dash leads to dash receptor. This one leads to analgesia, euphoria. Mu and kappa. These two. Mu kappa receptor leads to analgesia and euphoria. Dysphoria is mu receptor causes analgesia and euphoria. Kappa receptor causes dysphoria, and delta receptor causes affective tone changes. Okay, so what you should remember is mu is the main receptor and kappa is for dysphoria, means changes in the mood perceptions. Okay, then antagonist, what is used? This is very important, naloxone. Next, dash is long acting and used in de-addiction. Methadone. Methadone is very important. Okay, what is partial mu agonist? It has been asked multiple times. Okay, it is buprenorphine. Okay, what? Buprenorphine. And which is a weak mu agonist along with SNRI action? It is tramadol. Okay, tramadol. Next, never combine MAO inhibitors because it causes serotonin syndrome. If patient comes with lacrimation, yawning, diarrhea, and piloerection, think of withdrawal symptoms. What is the triad? Yes, very good. Respiratory depression plus coma plus one more is meiosis. That's why we see people who come with coma, okay, in emergency. Yes. Next, anti-epileptic is ketamine. Ketamine has multiple purposes also. It causes dissociative anesthesia also. We'll go through ketamine in detail. So first, ketamine, where does ketamine act? There are something known as the NMDA receptor, which are actually site of action of glutamate. Okay, they don't directly block glutamate. They actually block this NMDA receptor, which are involved in glutamate excitation. So basically, it inhibits this. Okay, so ketamine is something known as NMDA receptor inhibitor. So it decreases glutamate excitation. Now there are two main effects. One is it can cause anti-epileptic effect along with anti-analgesic effect, and second is it causes something known as dissociative anesthesia, where patient is aware his other reflexes are depressed, but he is not understanding what is going on. So okay, there will be like I have seen this in some pediatric patients who start to like use very bad words once ketamine is given. so it's fun to hear those things, but at the same time we should know it is because of dissociative anesthesia. So it is because of this cataleptic state. Now, because of which there will be like hallucinations and all. Okay. Now, dissociative anesthesia along with one important thing of ketamine, which is not done by other sedatives. Like whenever you want to sedate a patient, you either give midazolam or you can give lorazepam. Okay, there are multiple agents that are available, but ketamine is preferred in those patients who are in shock and all, because it doesn't decrease heart rate and it doesn't decrease BP. On the contrary, it increases these both things. Okay. Now, what is the utilization of this? See, whenever you give midazolam, it depresses everything. It even depresses your cardiovascular centers and your respiratory centers. So all depression causes what? It can be detrimental. It can cause death also in some cases. But ketamine doesn't decrease all this. It will actually increase heart rate. It will increase BP. So ketamine is actually a beneficial drug for us, especially in cases of low output states, like in shock and all. Next, in bronchodilation, ketamine has additional effect of causing bronchodilation. So it is also used as a bronchodilator reversal agent. Let's say, especially in pediatrics, for patients who undergo bronchoconstriction who are on ventilator and all, we need a sedative. Now we don't want drugs which causes bronchospasms. Okay, so we go for ketamine because it causes bronchodilation. And third is it has this dissociative amnesia like of thing which I have already explained. So what are the indications for anesthesia in patients who already have asthma? Because when you give anesthesia in patients with asthma, sometimes their asthma gets triggered. They go into bronchospasm. There ketamine comes into picture, especially in pediatrics. Second is in shock, and third is in burns dressing. See for burns dressing also, thing is that burns dressing is a very painful process. Okay, so there you want something like you don't want to intubate and all. You just want to have a dissociative type of anesthesia. There ketamine is very helpful. So one more important thing is ketamine increases cerebral blood flow. I told you it increases BP, it increases heart rate also. Along with it, it increases cerebral blood flow also. As a result of which, when there is head injury, we don't want more cerebral blood flow because it can increase intracranial bleeding. That's why it is avoided in head injury. Good thing about ketamine, as I told with the other sedatives, is that midazolam and fentanyl and all, they will abolish airway reflex, which means once you sedate a patient, these secretions and all, they can get clogged up and patient won't be able to clear it because the respiratory center and all the subcenters are depressed. But it doesn't happen in ketamine. It actually maintains airway reflexes, so patient can even have an irritation and he can actually imply that. Okay, he can actually cough or he can prevent that airway collapse. Okay, and third is nystagmus in higher doses causes nystagmus. Okay, next. What are the contraindications? Psychotic disorders, we don't give ketamine because already there is hallucinations caused by ketamine. Upon that, the psychotic patient itself has hallucinations. So you don't want the patient to go into mania or anything. Okay. And second is we don't use it in head injury. Next, there is something called as emergence delirium, which means after you have given ketamine, it will act for around like 10, 20 minutes or 30 minutes. And when the patient is coming out of that, he can have delirium, he can have confusion. That is known as emergence. When he is emerging out of anesthesia, he'll have this delirium. Second is hallucination, which I've talked. One bad thing about ketamine is it increases secretions. Okay, so in ICUs and all, we don't prefer ketamine unless it is indicated. Like bronchospasm, we prefer ketamine, but it also increases secretion. So this increased secretions is actually a not desired effect. Okay, because it can cause retention of the secretions. It can cause ventilator-associated pneumonia and all. So this is one side effect. And last one is increased ICP it causes. Okay, so we don't use it in cases where there is cerebral edema and all. So I think I have explained everything. Okay, so that's why you pre-medicate them with anticholinergic and midazolam because anticholinergic because it will increase secretion of ketamine. That's why we give anticholinergic which decreases secretions. Okay, most commonly we use glycopyrrolate. I think I have yes, I have explained everything. Okay, so let's answer the questions. Dash receptor antagonism, that is NMDA receptor antagonism. What type of anesthesia it causes? It causes dissociative anesthesia. Next. Safe in asthma? Yes, it causes bronchodilation. It is safe in asthma. Drug causing hallucinations is ketamine. That is basically anti-epileptic which causes hallucination. If increased BP plus heart rate is required, then we give ketamine. Okay. Pre-medicate it with what? With midazolam because midazolam gives that sedation effect and then along with that you give anticholinergic. Yes, we'll go to next, that is local anesthetics. So now we have gone into CNS part. Now we'll go into local anesthetics. Again, a very important question from anesthesia point of view. Okay. Now, mechanism of action of local anesthetic is basically again sodium channel only. So wherever these sodium channels are there on the peripheral nerves, no, see here, nerves, sodium influx causes depolarization. So what if you block the sodium influx? That causes no neuronal firing and there is like sensory loss. Okay. So that's the function of this local anesthetic. So they block this voltage gated sodium channels in the peripheral nerve. Okay. So that is the mechanism of action. Now, there are two types of mainly this local anesthetic. One is amides and second is esters. Esters always end with cane. Okay, so procaine, tetracaine. Esters and amides both end with cane. So example of esters are procaine and tetracaine. Amides are lidocaine and bupivacaine. These you need to remember. Okay, more than this I don't think it is required also. So amides important is this lidocaine, bupivacaine, these gets excreted via liver, whereas esters, no, they get excreted via plasma. In plasma there is something called as plasma cholinesterase. So this metabolizes the esters. So what is the order in which these sensations are blocked by this local anesthetic? So why do we give local anesthetic? For pain, right? So pain is the first, followed by what? Temperature, followed by third is touch, and last to go is motor. Okay, so this is the order: pain, temperature, touch and motor. This is very frequently asked. Match the following. Next, what is the effect of pH? If there is any infection, let's say there is a pus and you want to drain pus, and this pus will cause acidic pH, no? Because of inflammation and all. Okay, so this will actually decrease efficacy of local anesthetic. That's because the ions get trapped. We will not go in depth into that, okay, because these all are based on the membranes, okay, lipophilic and acidic environment and all. So we will not go, but just remember, in case of any pus or infection where acidic environment is there, their action of local anesthetic is decreased. Now, local anesthetic like lidocaine is always used with adrenaline because if you give, suppose you give local anesthetic at a site, so it will act here, but this drug is also carried away by the blood, right? So if you somehow decrease the flow of the blood to this area, it will prolong the action of this anesthetic. That's why it is used with this one, okay? It prolongs duration and it decreases absorption. But the downside is you can't use this adrenaline along with adrenaline where there are end arteries. End arteries like fingers, okay, fingers, ear lobules, at the glans penis, okay. So all these areas are innervated by end arteries. So there, if you use, it can cause gangrene because there is no collateral blood supply. So there we use only lignocaine. Now, this is what I was saying. Avoid adrenaline in end arteries. Okay, so you will give only lignocaine. Now, systemic toxicity can occur if they get absorbed into system large doses. So it can cause CNS excitation, seizure, depression, and all. And there is one component, that is this esters, no, whichever we had discussed. They have a component known as a PABA component in them. So if they are allergic to this, that is because of this PABA component allergy. Okay. Now, very important question from this, that is which local anesthetic is cardiotoxic? Yes, it is bupivacaine. Remember, this bupivacaine is used in pregnancy. Okay. During delivery it's used, and it has very long action also, long action along with the it is used in pregnancy. It is cardiotoxic. Second is lignocaine. We had also discussed this in antiarrhythmics. It is class 1B antiarrhythmic. Remember, there were three classes, 1A, 1B and 1C in sodium channel blockade. 1A had moderate effect on sodium, that is profound effect on depolarization, mild effect on depolarization, and then it had a normal potassium curve, slightly increased. 1B, which is lignocaine, it had shorter action potential duration and it had moderate effect on phase 0 of depolarization. And in 1C, it had very strong phase 0 depolarization and it had normal potassium duration. If you don't remember this, please go back and remember again. Okay, just go back. So cocaine is a local anesthetic which was used in earlier days. Okay, which is actually a potent vasoconstrictor also. Okay, so we don't use it nowadays. Next. If suppose there is toxicity of this local anesthetic, you treat it with IV lipid emulsion. So this is based on something known as a lipid sink theory. Okay, I think you shouldn't go into this much depth, but remember that we use this lipid emulsion in case of local anesthesia toxicity because they are more lipophilic. Okay. Yes. Next, I think I have explained everything. Okay. Longest acting is bupivacaine and ester hydrolyzed by plasma is procaine. Okay. That is what. Yeah. Okay. So blocks which channels? It blocks sodium channels. Sequence of block is first is pain followed by temperature, then we have temperature, and after temperature we have touch. Dash cane is the most cardiotoxic. It is, yes, bupivacaine. Next, lidocaine is also class 1B antiarrhythmic. Ester allergy is from which metabolite? It is from PABA metabolite. Drug of choice for local infiltration is, yes, it is lignocaine along with adrenaline. Longest acting is bupivacaine. Ester hydrolyzed by pseudocholinesterase, it's actually procaine. Okay, so we saw two drugs example, that is procaine and one more was tetracaine. Okay, so I think all these are easy to understand. So let's go with next, that is succinylcholine. Again, we have come from a local anesthetic to muscle relaxant now. Okay, so next is succinylcholine. Now we have come from general anesthetics, antiepileptics to local anesthetic. Okay, now we have come to neuromuscular blocking agents. Okay, so action of succinylcholine is basically muscle relaxation. That is what we want. Okay, so this succinylcholine is actually a depolarizing neuromuscular blocker and it acts on this nicotinic receptor present on the muscles. So this is the muscle end plate, succinylcholine, and it is acting on these receptors. Now the mechanism of action is actually this nicotinic receptors are stimulated multiple times, so it is persistently depolarized. That leads to paralysis. Okay, finally that is the mechanism of action. So depolarization, muscularization, what it causes, it causes persistent depolarization of nicotinic receptors, which finally leads to transient fasciculations and finally paralysis. Okay, so this is the mechanism of action. Now what is phase 1 and phase 2 depolarization? That also question will come. Okay, phase 1 depolarization and phase 2, and what is their significance? To understand this, what is phase 1 and phase 2, before that you will have to understand some more things. Okay, there is something, what happens is, this is nicotinic receptor. Okay, and this is nicotinic receptor at the muscle. Okay, this is the muscle. Okay, and here we have acetylcholine. Okay, acetylcholine comes here and it gets released here and it sits on nicotinic receptor, and then muscle action takes place. This is the normal process. Now, what is succinylcholine? These are acetylcholine molecules. Okay, succinylcholine is an antagonist, is an agonist. Okay, it's an agonist of acetylcholine. So what happens instead of acetylcholine, succinylcholine binds to this receptor. Okay, I'll mark it in green. The succinylcholine sits on this receptor, and it causes persistent depolarization. Now, because of this persistent depolarization, what will happen is slowly there will be fasciculation, twitching, and finally it will go into paralysis because it doesn't allow acetylcholine also to come and sit there, and it sits and it causes persistent depolarization. So this type of block is known as depolarizing block. Okay, so it sits there and it depolarizes the muscle. So this is depolarizing block. This is done only by succinylcholine. Okay. Now, what is non-depolarizing block? Non-depolarizing block. Non-depolarizing block means there are some acetylcholine antagonists. Okay, so let's say rocuronium. Okay, this is rocuronium. Now, rocuronium molecule will come and it will sit on this, and it will not allow acetylcholine to come and sit. Okay, it is a competitive antagonist. Okay, it's a competitive antagonist. It is not an agonist. It's an antagonist. In contrast to succinylcholine. Succinylcholine was an agonist. So now what will happen? It will not allow. So it's a competitive antagonist and will achieve block that is known as non-depolarizing, because we are not polarizing the muscle. We are not depolarizing the muscle. We are directly antagonizing the action of acetylcholine. So now you understood these two concepts, that is polarizing and depolarizing block. Okay. Now inside polarizing block, okay, there are two types, two phases, that is phase 1 and phase 2. Okay. So what happens in phase 1 is initially when you give succinylcholine, it goes into depolarizing block. Okay. We are not concerned about non-depolarizing, we are concerned about depolarizing block. So it goes into this phase 1. That is initially when you give succinylcholine, it will sit on this nicotinic receptor and it will continuously stimulate it, causing twitching and then fasciculation. Now, what happens in phase 2 is when large dose of succinylcholine is given. Where we do that, we do it in rapid sequence intubation, because you can't wait when you are going to intubate a patient. You can't wait for muscle relaxant action to come into effect. No, you'll have to do it quickly. So we'll give large dose of acetylcholine, and now what will happen is there is large dose of succinylcholine. Large dose of succinylcholine will sit, and then it will cause persistent depolarization. But along with depolarization, now it will cause decreased sensitization of this receptor. So even if this succinylcholine is gone, it has short duration of action. Now even if acetylcholine comes and sits, it will have no response. It will cause desensitization of that already activated nicotinic receptor, as a result of which you will have this paralysis again. Okay. Now what is the importance of this? Importance is that for a smaller duration, safe choice is phase 1 for small procedures and all. You can just give phase 1. So what happens in phase 1 and phase 2 is, in phase 1, acetylcholine sits on these receptors and it desensitizes it. So basically it's succinylcholine. Okay, succinylcholine sits and it desensitizes it. So basically once the effect is done, it will come back to normal. Okay, so this is what happens in phase 1 in lower doses. But what happens in phase 2 is succinylcholine sits for a longer duration of time when the dose is more, or if a sudden infusion is given, and it not only desensitizes the receptor, it also prevents resensitization, as a result of which these receptors are of no use now. It will simulate what happens in non-depolarizing block. Okay, just like in when you give rocuronium or vecuronium, what happens is there occurs non-depolarizing. It is not depolarizing, it is non-depolarizing, so it will stimulate it. So how to differentiate whether it is phase 1 or phase 2 depolarization is, in phase 1 and 2, we use some clinical test known as train of 4, TOF, which means we give 4 electrical impulses to the nerves, 1, 2, 3, 4. If this, what happens in, first we'll say what happens in non-depolarizing, which means in case of muscle relaxants like vecuronium, rocuronium and all, this train of 4, it fades, which means the impulses, the second, third, fourth impulses are decreasing in intensity. So similar train of 4, this is known as fade. Okay, train of 4 fade. This train of 4 fade is present in phase 2 block. Okay, when the resensitization is affected and the receptor is not active. So because of higher dose, that time what happens? Train of 4 fade is present. Whereas in phase 1, there is no train of 4 fade. Fade is absent. Okay, so these are simple questions which can come in as MCQs. If you know the concept, it's very easy to solve this. Okay, so this is what is meant here. See here, persistent depolarization causes phase 1, which causes transient fasciculations and then causes paralysis. Now what are the indications of succinylcholine? It is used in rapid sequence intubation, it is used in electroconvulsive therapy, and in case of laryngospasm. So basically where you suddenly want to create a muscle paralysis quickly, you use this because it has got rapid onset of action within 5 to 10 minutes. Now succinylcholine metabolism is via pseudocholine esterase. So remember that acetylcholine is via acetylcholine esterase. Okay, so here succinylcholine is via pseudocholine esterase. Now what are the adverse effects? One is hyperkalemia, malignant hyperthermia. This question will be repeatedly asked. Okay, malignant hyperthermia. It can also cause bradycardia and increased in pressures, intraocular pressure and ICP. But most important out of this is hyperkalemia and malignant hyperthermia. Okay, so what are the contraindications? So avoid succinylcholine choline in case of burns. Okay, burns we don't use because there is risk of hyperkalemia also. Second is in trauma, and third is in any case of neuromuscular disease because it causes more paralysis, right? Next, important thing is that this phase 1, whichever is there, no, say this phase 1, this is not reversed. This is phase 1 is not reversed by neostigmine. Okay, so neostigmine has no effect on this, but neostigmine effect is present on phase 2 and non-depolarizing block in both neostigmine. Effect is present. Okay, so this can also come as a MCQ, especially in INICET. So contraindicated in glaucoma because it will increase intraocular pressure. So what happens is if there is a genetic mutation and there is some there are some people who have modified pseudocholinesterase, which is known as atypical pseudocholinesterase. In that, what happens, there will be prolonged apnea. That is, patient when after intubation or maybe after inducing with succinylcholine, he will take so much time to recover back in extubation. Okay, so that is because of atypical pseudocholinesterase. Okay, now second is phase 2 block will occur when we give repeated doses of succinylcholine, which I have already told, and succinylcholine will trigger malignant hyperthermia when used with halothane. See, halothane is also an anesthetic agent. So when you combine an anesthetic agent with a neuromuscular blocker such as succinylcholine, these two combination leads to malignant hyperthermia. Okay, so I think I have explained all this. There is no doubt with this. So malignant hyperthermia, what is the treatment of choice? It is dantrolene. Okay, so dantrolene. Okay, so let's go to the questions. See, what is the mechanism of action? Dash agonist. So this is, so where is the site of action of succinylcholine? It is a site of action of acetylcholine. Same, that is nothing but nicotine receptors. So it is a nicotine agonist. Next, duration is 5 to 10 minutes. Metabolized by which? Yes, pseudocholinesterase. Okay, pseudocholinesterase. Next, triggers dash with malignant with halothane. It is, yes, malignant hyperthermia. Not reversed by dash in phase 1. So in phase 1, when we give neostigmine, it is not reversed, but in phase 2, the effect will be reversed by neostigmine. Contraindicated in which? Yes, it is contraindicated in hyperkalemia. Okay, and it's contraindicated in glaucoma, and it is contraindicated in any neuromuscular disease. Drug of choice for rapid intubation is, yes, very good. For rapid intubation, rapid sequence intubation, we call it as RSI. It is succinylcholine. Treat malignant hyperthermia with what? Dantrolene. It is basically IV dantrolene. Okay. Yes. So I have told you which are the important questions in this everything. Okay. Now we'll see what is reversal of neuromuscular blockade. So basically I told you, that neostigmine is used for reversal of neuromuscular blockade. Okay. So same thing. See here. So what happens is there are two type of muscular relaxant. I told you, muscle relaxants. One is succinylcholine, and the second is non-depolarizing, such as rocuronium, vecuronium, all those comes under non-depolarizing. Okay, so what happens is when acetylcholine is released, these non-depolarizing agents, they will block these receptors, acetylcholine receptor. They are not agonists, they are basically antagonists of it. Okay, so what happens is acetylcholine can't act on this. Okay, so neostigmine is an acetylcholine esterase inhibitor. So what it does is it will break down whatever acetylcholine is there in the synaptic cleft. But if you give more of neostigmine, what will happen is it will prevent anticholinesterase from breaking this acetylcholine and will have a competitive antagonism. Okay, so as a result, increased acetylcholine at neuromuscular receptors, and hence will have some movements. Okay, that is reversal of neuromuscular blockade will happen. So this is a type of competitive antagonism. Okay, so next, what happens if what is Sugama Dex? Okay, so basically it is also a reversal agent. What it will do is it will encapsulate. See here, it will encapsulate these rocuronium, vecuronium and all. Okay, so this neuromuscular blockade agents, it will encapsulate and it will cause its reversal effect. So very important is in phase 1, I told you again and again, phase 1 can't be reversed by neostigmine. Okay, so it is worsened by neostigmine. Okay, so for rocuronium and vecuronium, we give Sugama Dex. Okay, so again, anticholinesterase, that is neostigmine and Sugama Dex, these are the two types of reversal agents we use. Okay, now what is the effect? Increased acetylcholinesterase at neuromuscular junction, but along with this, neostigmine has some other effects. So neostigmine is an anticholinesterase, so it is anticholinergic. Okay, so it is basically anticholinergic. So what it has some muscarinic side effects also. Sorry, it is a cholinergic. Okay, sorry, it is a cholinergic because it inhibits anticholinesterase. Okay. Yes, so it is a cholinergic. It increases acetylcholine at the synapse. So as a result of which, there will be some parasympathetic effects, that is bradycardia, secretions. Okay, so that's why we pair neostigmine along with some antimuscarinic or that is anticholinergic, that is glycopyrrolate or atropine, so that this muscarinic or parasympathetic effects are blocked out. Okay. See, these are the two phases of succinylcholine. Phase 1 is depolarizing block, where membrane depolarizing to reversal, we can actually reverse. And here there is prolonged desensitization, as a result of which here train of 4 will fade actually. Here train of 4 won't fade. Neostigmine will not be useful here, but neostigmine will be useful here. Okay. Next, how will you monitor? That is using train of 4, that is I told, it will give electrical impulses, and then we'll calculate actually what is the intensity of signal in the first T1, that is first signal, to intensity of fourth signal. So we'll take this ratio. If that ratio is more than 0.9, that means we can extubate, which means more than 0.9 means the whatever first signal is given, that is almost equal to fourth signal. Okay, less than 0.9 means first signal is higher, T4 will be smaller. Okay, so that time the ratio will be less than 0.9. So if the ratio is more than 0.9, then we'll know that the patient is ready for extubation. Now remember, neostigmine plus glycopyrrolate. Okay, the meaning of this is if you give neostigmine without glycopyrrolate, okay, then it can cause severe bradycardia because of unopposed muscarinic or parasympathetic action. Okay. Second is deep block and number of twitches. Okay, the meaning of this is that whenever the block is very deep, okay, which means you have given large doses, and when you try reversal, initially the patient will improve, but later on there will be residual neuromuscular weakness. Okay, that is known as recurarization effect. Okay, so this is just a concept. I think you don't have to go in detail. Third is in phase 1 of succinylcholine, if you give neostigmine, there is not much use because it doesn't act. So you know that neostigmine doesn't act on when the succinylcholine is on phase 1. How you know it is in phase 1? Train of 4 fade is not present. Okay. Yes. Next, Sugamadex. Okay, so what happens in Sugamadex is basically it encapsulates steroids. Okay, so this Vecuronium, all these are like related to steroids. So what this will do, it will also try to encapsulate estrogen progesterone, as a result of which OCP failure can occur. Okay, so Sugamadex is to be used in caution when using along with contraceptives. Second is regarding etracurium, which is a non-depolarizing agent. So this etracurium, its elimination is not dependent on liver metabolism or kidney metabolism, because its excretion is dependent on independent mechanism, that is known as Hoffman elimination, where the molecule itself undergoes transformation without depending on anything. The only thing that depends is the pH. If pH is acidotic, then there will be increased conversion of etracurium into its metabolites. If pH is low, then conversion will be less. So it is organ independent, and hence this etracurium, which is a neuromuscular blocking agent, it can be given in any renal failure or hepatic failure. We can safely give it. Now what is edrophonium? Edrophonium was used earlier to diagnose myasthenia gravis. Okay, we had edrophonium test, myasthenia gravis. So nowadays we don't use. Earlier we used to have edrophonium. Okay, so basically what is this? Assess train of 4 first. Okay, and after assessing train of 4, if you see a fade, if you feel that you have to do reversal, then you choose the agent, whether you have to give Sugamadex or you have to give neostigmine. Okay, and then if you are giving neostigmine, you have to give antimuscarinic agent, that is glycopyrrolate or atropine, and then you check for train of 4 strength, how much it is recovered. Okay, so dose of this reversal agent, that is Sugamadex or neostigmine, is based on what is the train of 4 output. Okay, what is the ratio? After giving this reversal agent, if a train of 4 ratio is more than 0.9, then you can extubate the patient. Okay. Yes, I think I have covered everything. Yes, so let's go to the questions. See, I'll just go in little bit depth here. So non-depolarizing agents are rocuronium, vecuronium, and etracurium. Okay. Neostigmine, how does it act? It increases acetylcholine at neuromuscular junction, and it is given with antimuscarinic, that is glycopyrrolate. So when do you give this reversal agent? Once you see that after doing a train of 4, there are muscular twitches. Okay, so that time you give. Next, antimuscarinic, you add glycopyrrolate because it will decrease secretions also. It will decrease bradycardia, which will be caused by neostigmine. Now, dash drugs encapsulate steroidal neuromuscular blocking agent. That is for rocuronium, we get rapid reversal. Which is this agent? Yes, it is Sugamadex. Next, succinylcholine phase 1 is not reversed by neostigmine. Just remember this much. So it worsens depolarizing block. Succinylcholine phase 2 may respond to neostigmine. Phase 2 is caused by prolonged exposure state to succinylcholine. Monitoring dash TOF. TOF is what? Train of 4 to assess recovery. If it is more than 0.9, we can extubate the patient. Okay. Next, dash recovers via Hoffman elimination. We have etracurium. Etracurium is dependent on Hoffman elimination. Best reversal for rocuronium is, yes, it is Sugamadex. Drug paired with neostigmine is, yes, glycopyrrolate, which is an anticholinergic or antimuscarinic. Next, confirm TOF is dash before extubation. It is more than or equal to 0.9. Again, we'll revisit this topic in anesthesia. Okay, I think everyone is clear about this. So now we'll go to next topic, that is antibiotics. Okay, now we are going to antibiotics. So first is penicillin. So mechanism of action of penicillin is what you need to understand. So basically penicillin acts on cell wall of the bacteria. Okay, it is cell wall. Okay, so on the cell wall, these are the interlinking chains of the cell wall. So I'll explain it in very simple terms. So this is the NAG/NAM cell wall chains. Okay, so this transpeptidase enzyme, which has a penicillin binding protein also inside it. So this transpeptidase enzyme is responsible for cross-linking these peptide chains. Okay, so peptide cross-linking is done by this transpeptidase that maintains bacterial cell wall integrity. Now, what this beta lactams will do, penicillins, they will inhibit this transpeptidase enzyme and they will prevent this cross-linking, as a result of which structural cell wall integrity is lost and bacteria will undergo lysis, that is bactericidal effect. Okay, so basically what you have to see for MCQ is it blocks transpeptidase, okay, causing lysis. So we have oral synthetic penicillins and we have natural penicillins. Under natural penicillins, it is known as penicillin G, okay, which is given by IV route, and oral natural penicillin is known as penicillin V. So penicillin G and V are natural penicillins and their role is very limited now. It is given for streptococcus infection and it is given for syphilis. Okay, only these two conditions you need to remember. They are basically gram positive. Now, synthetic form of this, that is amino penicillins, that is we basically combine amino group in them. So two examples are ampicillin and amoxicillin. This ampi and amoxi, they are given for gram positive as well as gram negative, like E. coli, H. influenza, and in otitis media, etc. Okay. Then what happened is there were some bacteria which broke down penicillin, okay, that produced beta lactamase, that is penicillinase. So for that, we came up with a drug known as cloxacillin. So what this penicillin resistance were doing is they were inhibiting this enzyme, okay, that is they were resistant to this transpeptidase. So we came up with cloxacillin, especially for methicillin sensitive Staph aureus. This cloxacillin made wonders. Okay. Now there were some bacteria such as Pseudomonas which which were resistant to our synthetic and amino penicillin. So there we had some extended penicillin called as piperacillin. Okay. So piperacillin is an extended penicillin which acts against Pseudomonas. Now what is the mechanism of action of this resistance? How resistance occurs is it will cause this beta lactamase enzyme, no? So it will try to evade it, or it will try to gain resistance to it. That is by alteration of this penicillin binding protein. So that protein where penicillin goes and bind in the enzyme, that itself is altered. So that is the mechanism of action of this MRSA. Okay. So in MRSA, if they ask what is the mechanism of action of resistance in MRSA, it is by penicillin binding protein alteration. Okay. And as a result of which, for MRSA, we'll have to go for other choices such as vancomycin and linezolid. Okay. So what are some exam things you should know? One is it can cause type 1 anaphylaxis reaction, penicillin. Okay. Second is don't mix penicillin and aminoglycoside in the same syringe. And third is ampicillin rash in EBV is not linked to any allergy. So what happens is when you give ampicillin in EBV infection, it will cause rash because of autoimmune reasons. It is not because of allergy to ampicillin. Okay. So this one rare thing can be asked in INICET. Okay. Next, which is the acid stable penicillin? Yes, it is penicillin V, which can be given by oral route. So beta lactamase inhibitors are there, like for example amoxicillin. There is clavulanic acid. Clavulanic acid is actually beta lactamase inhibitor, so that's why we give it as combination. So next, there is something called a Jarisch-Hersheimer reaction, which occurs in syphilis. Post syphilis, when syphilitic bacteria are like this treponema, they are like lysed, their cell walls and their contents, bacterial content, that will actually cause a type of reaction. Okay, so that is known as a Jarisch-Hersheimer reaction that occurs after syphilis therapy. So I think I have explained everything. Beta lactam, penicillin binding protein, no cross-linking, cell wall and lysis. Drug of choice for syphilis is penicillin G. So IV penicillin G right now, I told you, one is for streptococcal infection and syphilis. There are no other indications otherwise. Beta lactamase combination is amoxicillin plus clavulanic acid. And when in Epstein-Barr virus rash occurs, it is the drug implicated is usually when ampicillin is given, rash occurs. It is not because of EBV. It is basically a mild immune reaction, and we can give penicillin. It is not penicillin allergy. Okay. So we usually do skin test before first dose. Okay. Whenever we give penicillin G, for example, especially for rheumatic heart disease prophylaxis, we give penicillin G. That time we do actually skin test to see if there is hypersensitivity. Next, renal dose adjusting is required in penicillin because it is renal excretion, and clavulanate I have already discussed. Okay, so let's go to the questions. Irreversibly binds to what? It irreversibly binds to penicillin binding protein. Okay, irreversibly. Okay. Next, natural penicillin G, amino penicillin. Which are amino penicillins? Yes, it is ampicillin and amoxicillin. This can be asked in your exam. Which are the types of penicillins? Okay. Extended penicillin is piperacillin, but we commonly call it as piptas, piperacillin plus tazobactam. Okay. Next, acid stable, that is penicillin V. Next, dash reaction occurs with syphilis therapy. Yes, Jarisch-Hersheimer reaction. Next, drug of choice for syphilis is IV penicillin G. Next, dash is given before first dose if history is unknown. Yes, we do skin test. Okay, skin test is done before first dose if we don't have any allergy history. Okay. Yes, so we'll go to the next antibiotic, that is macrolides, a very important group of antibiotics. See, in antibiotics, your most confusing question in MCQs will always be the mechanism of action, nothing else, okay? So this macrolides like erythromycin, azithromycin, okay? So all these, they will be acting on this 50S part of ribosome, okay? So remember it blocks the translocation in 50S. So ribosome, you know, has 50S and 30S, eukaryotic, okay? Sorry, prokaryotic. So this acts on this 50S ribosome of the bacteria. So this 50S ribosome, okay, and then you have here tRNA, which is undergoing translocation here, okay. Translocation is going on, and this translocation is blocked. This peptide transferase, no, that is blocked by this macrolide, okay. So this translocation in 50S blockade is the mechanism of action of mechanism of action of macrolide. This is what you need to remember. So it just inhibits protein synthesis, so it doesn't lyse the cell, okay. It is not a bactericidal, hence it is a bacteriostatic protein synthesis inhibitor, okay. Yes, so what are the different drugs you have under macrolides? Yes, one is erythromycin, clarithromycin and azithromycin. So where are these used? Remember that anytime macrolides, remember atypical organisms. So what are atypical organisms? They're Mycoplasma, Chlamydia and Legionella. So basically they are used in URTI, atypical pneumonias, okay, atypical pneumonias, STDs, diphtheria carrier. So these are mainly for atypical bacteria. You will go for macrolides, okay. Next, so what is the resistance mechanism? So what will happen is there will be binding site change where this rRNA comes and binds, no? So that binding site is changed in this 50S chromosome, 50S ribosome, okay. So that is the mechanism for resistance, okay. This methylation of 23S rRNA takes place, and hence it alters the binding site of this macrolides. So what are the pharmacological interaction? Yes, erythromycin is actually CYP3A4 inhibitor. Remember, in pharmacokinetics I told you, if something is an enzyme inhibitor, then it will cause toxicity of the other drugs which are metabolized to that enzyme. So it will cause toxicity of warfarin, okay. So remember, erythromycin, we don't give on a patient with the warfarin, we should be very cautious regarding erythromycin, okay, whenever you start erythromycin. Next, another thing which you already saw with statins is erythromycin when combined with statins causes what? Rhabdomyolysis. Yes, rhabdomyolysis. Next, erythromycin also, azithromycin and erythromycin both cause prolonged QT interval, but erythromycin causes more than azithromycin. So prolongation of QT interval is also there. And next is erythromycin, this particular particular compound called erythromycin estolate actually can lead to cholestatic hepatitis, but in rare cases, okay. So azithromycin has least CYP interaction. So yes, when given choice, erythromycin or azithromycin, you should choose azithromycin. Clarithromycin actually increases digoxin toxicity, and these macrolides are used in prophylaxis of MAC infections, okay. So what is MAC infection? MAC is nothing but Mycobacterium avium complex, okay. So those mycobacterial infections which are there, for that prophylaxis will give macrolides. So remember, macrolides bind 50S, it blocks translocation and inhibits protein synthesis, so it is bacteriostatic. What are the side effects that you should be knowing? One is prolongation of QT interval. Second is rhabdomyolysis along with statins. Third is azithromycin has longer T half, so once daily dosing is enough. And we combine with beta lactams for atypical coverage, because some atypical coverage also are gram positive, so they can be they can be inhibited or lysed by beta lactams, and additional atypical will be lysed by this will be inhibited by this macrolides. So which is a drug causing cholestatic jaundice? Yes, it is erythromycin. Safe for pregnancy and atypical pneumonia? Yes, it is azithromycin, okay. Next mechanism we have already discussed. So I think we have discussed everything. These are the extra side effects which are there, okay. Yes, so azithromycin is coverage is broad and safe in pregnancy, so you can give azithromycin in pregnancy. So we'll go through the questions. Binds which subunit of ribosome? 50S subunit, so there should be no confusion regarding this. Spectrum is, it is gram positive along with atypical coverage. Next, pharmacology, CYP3A4, it is inhibitor, not inducer, okay, inhibitor, so it will increase warfarin levels. Next, dash is equal to least CYP interaction? Yes, very good, it is azithromycin which has least CYP interaction. Dash increases digoxin toxicity? Yes, it is clarithromycin. We don't use clarithromycin too much nowadays, okay, but it increases digoxin toxicity. What is used in MAC prophylaxis? Yes, very good, it is macrolides are used in MAC prophylaxis. Next, avoid erythromycin with statin because it causes what? It causes rhabdomyolysis. Causes dash erythromycin estolate? Yes, it causes cholestatic hepatitis. Cholestatic hepatitis. If safe in pregnancy plus atypical, which drug is safe in pregnancy and covers atypical organisms? Yes, it is azithromycin. Next, avoid existing what? Avoid existing QT prolongation, okay, because this is the dangerous side effect you are concerned with. Next, we'll go to fluoroquinolones. Again, this basically students get confused with mechanism of action of macrolides, fluoroquinolones, linezolid, all this. So we'll have image-based mnemonics so that you don't get confused. So what fluoroquinolones does is, see, there is an enzyme. When DNA synthesis happens, DNA can supercoil. Okay, this supercoiled DNA needs to be uncoiled. Okay. So there we have this enzyme known as topoisomerase. This topoisomerase and DNA garase are two enzymes. Topoisomerase is the same enzyme present in gram-positive organisms. DNA garase is the same enzyme present in gram-negative. Okay, so DNA garase is basically topoisomerase 2 and this is topoisomerase 4. So in gram-negative and gram-positive, this enzyme does what? Uncoiling of DNA. Okay, so whatever coiling is there, it will uncoil the DNA. But now what will happen is that this fluoroquinolones, they'll inhibit these enzymes, DNA garase and topoisomerase. That is, in gram-negative, it will inhibit this enzyme, in gram-positive, it will inhibit topoisomerase. Now this, because of this, what happens? There will be breakage in the DNA strands and it will cause bacterial cell death. So what is the mechanism of action of fluoroquinolones? It is topoisomerase 2 or 4 inhibition, in other words DNA garase inhibition, causing bactericidal effects. So which are the generations we have? We have total 4 generations. First generation you don't have to remember because we don't use it nowadays. Ciprofloxacin is second generation, levofloxacin is third, and moxifloxacin is fourth. This is the only thing that you need to remember. Now, what are their targets? Yes, it is gram negative. Okay, gram negative because they are gyrase. Okay. Second is pseudomonas, and third is atypical organisms, which mainly come under this topoisomerase 4. Okay, so these 3 are the main targets. Now, what are the indications? UTI. Yes, you use ciprofloxacin, you use ofloxacin for UTI. You use ciprofloxacin for travelers diarrhea. You use in typhoid also ciprofloxacin, ofloxacin is also used. These are used in atypical community acquired pneumonias also. Atypical, okay. And then like levofloxacin is used, okay. And in TB second line, moxifloxacin and levofloxacin both are used, okay. So these are some of the indications of this DNA garase inhibitors of fluoroquinolones. Now, it should be avoided in pregnancy. Remember, pregnancy we don't give. It should be avoided in children also because it can cause toxicity to this cartilages. Okay, so cartilage toxicity is by which drugs? Fluoroquinolones. Now, next, increased QT syndrome occurs with macrolides and it is not with the fluoroquinolones. And NSAIDs, if you give along with this, so yes, NSAIDs along with fluoroquinolones can cause seizure. That is because NSAIDs, this fluoroquinolones, they actually decrease the GABA threshold. Okay, so that's why we avoid NSAIDs along with this fluoroquinolones. Okay, next. In stomach, what happens is these are chelated by calcium and iron, so it can decrease absorption. So in pharmacokinetics of fluoroquinolones, you should remember this moxifloxacin, levofloxacin, ciprofloxacin are actually chelated by calcium and iron. Okay. Next, ciprofloxacin inhibits CYP-A1-2 and hence we have an interaction. CYP-1A2 is also involved in theophylline level. So since it inhibits, this will cause toxicity of theophylline. Next, excretion is by kidney. So moxifloxacin has so this all the fluoroquinolones, they will be excreted via renal route only, but except moxifloxacin, which is not excreted via renal route. So it is safe to be used in renal failure. Okay. So what is the drug of choice for Pseudomonas UTI? Yes, it is ciprofloxacin. I told you, see here Pseudomonas and there is UTI over here. Next, drug causing tendon rupture, I told you, which causes cartilage toxicity? Yes, it is fluoroquinolones. Next, DNA garase target is fluoroquinolones. Okay, so I think I have explained everything. Okay, so let's move on to the question session. Fluoroquinolones inhibit dash enzyme and dash. So in gram negative, it inhibits topoisomerase 2, that is nothing but DNA gyrase, and in gram positive, it inhibits topoisomerase 4. Okay, next spectrum. What is the spectrum? Yes, it is gram positive rods, pseudomonas and atypicals. Okay, am I right? Sorry, gram negative rods. Sorry. This is gram negative rods. Okay, pseudomonas and atypicals. Then dash inhibits CYP-A1A2, CYP-1A2 increase theophylline levels. It is Ciplox. Okay, next. There is no renal clearance for which one? Moxifloxacin. Avoid pregnancy children because it causes cartilage toxicity. Drug of choice for Pseudomonas UTI is? Yes, it is Ciplox. Drug causing tendon rupture? Yes, very good. It is fluoroquinolones. That's it, I think. Yes. So we'll go on to the next drug, that is tetracyclines. So again, tetracyclines and macrolides, many people confuse often. Okay, so tetracyclines, we have basically 3 drugs: tetracycline, doxycycline, and minocycline. So we'll go to the images and we'll understand what is the mechanism of action. So this acts on again on 30S. So what was acting on 50S? Yes, very good. 50S action was by, yes, it was by macrolides, azithromycin, clarithromycin, and erythromycin. But in case of tetracyclines, that is tetracycline and minocycline and doxycycline, the action is via 30S. So this unit, okay, so this 30S, okay. So what happens is there is amino acyl tRNA. So this tetracycline, they'll block this tRNA entry into the 30S ribosome, okay. So what is the mechanism of action? It binds to 30S and it will inhibit this amino acyl tRNA entry. See, you can see a door here, okay. So this tetracycline will block the entry of this one to this, okay. That's why I told visual mnemonics are so helpful. So as a result of which protein synthesis won't take place. As a result, it is what? It is bacteriostatic. Okay, so there shouldn't be any confusion. Next, which are the three drugs? Tetracycline, doxycycline, minocycline, and you see the spectrum. It is used for atypical infections, just like macrolides. Here, rickettsia, atypical, chlamydia, atypical, mycoplasma, atypical. One more off-label uses for acne, okay, where we use tetracyclines. Specifically minocycline, okay, and even doxycycline. So absorption interference, yes, just like fluoroquinolones, which were not absorbed because of calcium and iron chelation. Here also same thing, calcium, magnesium, iron will cause chelation of these tetracyclines, and hence its absorption is decreased by milk, antacids, and iron. Same holds true for fluoroquinones. That's why we avoid it along with milk and with vegetables and all. Okay. Next, this is also contraindicated in pregnancy, and you should never give along with less than 8 years, and you shouldn't give with antacids because it can cause in children what is known as a permanent enamel staining, okay, this tetracyclines. Next, it should not give with milk and antacids because it will kill it and there won't be any action of this tetracyclines. There was one outdated drug which caused Fanconi syndrome. That is when tetracyclines undergo expiry, basically they'll cause Fanconi syndrome. So this is a rare question that can be asked. Now, doxycycline is safe in renal failure because it has no renal excretion, but it has actually fecal excretion. So if anyone asks you which drug is excreted in the fecal route and not by renal route, which tetracycline it is, doxycycline. Next, it decreases ADH also. That's why in SIDH what happens? SIADH, basically ADH levels are increased, okay? So that's why it can be used for SIDH also. And minocycline specifically has one side effect, that is vestibular toxicity, so it can cause vestibular symptoms like headache, dizziness and all. Okay. Next, so this tetracycline, they bind to 30S, not 50S, decrease tRNA entry, and there will be growth arrest of the cell. Okay. And one thing is, whenever you are using doxycycline and tetracycline, you have to monitor for photosensitivity. When I talked about drugs causing photosensitivity, doxycycline and tetracycline were also among them, okay, minocycline specifically. So you should take with water and remain upright because it can cause GI distress. So this is one thing that can be coming in your question. So what is the drug of choice for rickettsia, chlamydia? Yes, it is doxycycline, very good. Which drug causes tooth discoloration? Yes, very good, it is tetracycline. And which is safe in renal failure? Doxycycline, okay. So we'll go through the questions quickly. See, mechanism of action is what? Binding to 30S, and it inhibits tRNA attachment. Okay. Next, doxycycline is excreted via what? Doxycycline is excreted via fecal excretion. Okay, it is not by renal. Dash causes vestibular toxicity. Yes, minocycline. Okay, minocycline specifically causes vestibular toxicity. Drug of choice for rickettsia and chlamydia is what? Tetracyclines only. Okay, we use doxy mainly. Okay, and which is safe in renal failure? Yes, again it is doxy. Yes, so we'll go to next topic, that is vancomycin. So vancomycin is somewhat similar to penicillin mechanism only, okay, but the difference is in the mechanism in how it acts. So this is basically the peptidoglycan cell wall layer of bacteria, and here we have DAL, that is D-alanine residues, okay, and these D-alanine residues, so their cross-linking is required for this proper chain synthesis. So what this vancomycin does is, this is vancomycin, the purple color. So it will combine all this, it will bind to this D-alanine residues. And when vancomycin binds to it, this transpeptidase polymerase, okay, this transpeptidase enzyme can't act. As a result of which peptidoglycan polymerization doesn't occur, cell wall synthesis is not happening, and as a result of which there is bactericidal-like action. Final action is similar to that of penicillins only, but there is just a minor difference in where it acts, because penicillin acts on penicillin binding protein in that transpeptidase enzyme, but here it is basically combining to alanine residues. Okay. So what is the spectrum of action? Again, just like penicillin only, it is gram positive, but here thing is, it will cover MRSA also. We saw that when penicillin binding protein is altered, it will cause MRSA resistance. Okay, that is methylene sensitivity is lost, as a result of which we have MRSA infection. So for this MRSA, this vancomycin will be the drug of choice. Okay, and also in Clostridium difficile infection, oral vancomycin is a drug of choice. This is a repeatedly asked question. Oral vancomycin, there is only one indication that you need to remember, that is for Clostridium difficile pseudomembranous colitis. Okay. Yes. Now, what is vancomycin resistant enterococcus? What it does is, instead of alanine, there is a lactate substitution, as a result of which vancomycin can't act. So we have vancomycin resistant enterococcus. And what is the drug of choice for vancomycin resistant enterococcus? It's linezolid. Okay. So in this case, we use linezolid. So what are the side effects of vancomycin? One is it is nephrotoxic, ototoxic. We discussed this in renal drugs also. One more drug which causes similar actions is aminoglycosides, which we'll be discussing in the further slides. One more is vancomycin can cause release of histamine, that can cause red band syndrome, and I myself have seen some 4 to 5 cases in my 3 years of residency. Red band syndrome caused because of vancomycin. Okay. Next, we use vancomycin monitoring for toxicity, and here we'll use trough levels. I think I have discussed this in therapeutic drug monitoring, where we use trough levels and all. So the trough levels, that is bottom levels, okay, trough levels are used for monitoring vancomycin toxicity. So what happens is vancomycin should be given slowly over 1 hour, but if it is given quickly, then it can cause red man syndrome. It can cause nephrotoxicity when it is combined with aminoglycosides like vancomycin plus gentamicin or vancomycin plus amic acid. So such combinations can lead to nephrotoxicity. Next is it is not effective for gram negative at all, because again it it is too large to enter into the gram negative cell wall, into the gram negative bacteria. So that's why it is not effective for gram negative. It is for gram positive organisms only. Now you have to infuse slowly. If there is penicillin allergy, but still you can use vancomycin. Okay, so there is no cross reactivity among penicillin and vancomycin. And oral drug, that is oral vancomycin, is used only in case of Clostridium difficile. Now next, it is excreted via renal route. Okay, it can cause nephrotoxicity also. That's why we'll have to adjust the dose in renal failure. Other things, I think I have explained everything. Okay, we'll go to the questions now. Okay, so let's solve questions. So spectrum is gram positive, including what? One is Clostridium difficile and another is MRSA. Okay, next, adverse effects are red man syndrome, which will definitely be asked in your MCQs. Next, infuse slowly to avoid what? Histamine release that causes red man syndrome. Additive nephrotoxicity is with what? Aminoglycosides, because usually we combine 2-3 antibiotics. Drug of choice for vancomycin is, for MRSA is vancomycin. Drug resistance mechanism is DALA gets converted into D-LAC, okay, lactate. Yes, so let's move on to the next antibiotic, that is sulfonamides. And here we have one important antibiotic, that is sulfamethoxazole and trimethoprim. Okay, so we'll see how these act. So basically what happens is, for in bacteria, okay, in bacteria also needs folate, right? So for that folate synthesis in bacteria, we have two compounds. One is PABA, which is required. Okay, this PABA is para-aminobenzoic acid. Now with the sulfonamide drug, it is similar to PABA. So this PABA analog, that is sulfonamide, will mimic action of PABA, and it will block this enzyme. See, this PABA is metabolized by this dihydroteroid synthetase, and then it will be used for folate. Okay, it will get converted into folate. Now what will happen is the sulfonamide will block this enzyme, okay, because it is a structural analog, and that's why we'll have decrease in this one folate, and hence it will be bacteriostatic, not bactericidal, because it is not something which is required for structural integrity of the bacterial cell wall. It is required for a function of the cell. That's why it is bacteriostatic. So we have three main drugs. One is sulfamethoxazole, very commonly used. Second is sulfadiazine, and next one is sulfasalazine. Okay, so these three sulfa drugs. Now sulfamethoxazole plus trimethoprim, this combination. Here we have trimethoprim also. See, sulfamethoxazole is bacteriostatic, but after this, along with this trimethoprim is there. Now this combination causes sequential block, which ultimately hampers lot of function in the cell. So this becomes cidal. So very important in your question, if you have just sulfamethoxazole, it is bacteriostatic, but along with trimethoprim, this combination is known as clotrimazole. Okay, this combination is bactericidal. Okay, so these are used for clotrimazole is used for UTI, it is used in nocardiosis, it is used for pyrimethamine, is used for toxoplasma also. Now what are the adverse effects? One is it can precipitate crystals in the urine. Okay, so it can cause crystalluria. It can aggravate kernicterus in newborns. Okay, next, this sulfamethoxazole, it is one of the drugs known to cause hemolysis in G6PD and also photosensitivity. So these four, remember, kernicterus, hemolysis, photosensitivity, and crystalluria, these four are the most important side effects of these sulfonamides. Next, you will avoid in pregnancy and newborns, because again we don't want to cause hemolysis and all. Second is it will cause CYP inhibition, so it can also cause increased INR levels, that is warfarin toxicity. So what is the other drug which also cause similar effect? Yes, just remember. Yes, very good. Yes, it is erythromycin, that is macrolides, and also ciprofloxacin. Okay, so it causes crystalluria in acidic urine, so that's why we need to hydrate patient whenever we are giving sulfamethoxazole. So next is sulfasalazine, the third category of drug which you saw in this, that is used for treatment of irritable bowel disease. Okay, so we'll use there. Next, it has cross reactivity with loop and thiazide diuretics. Remember this, sulfonamides. That is because this loop diuretics also contain sulfa drugs, sulfa group. Okay, and because of the sulfa group, there can be cross reactivity and allergy. That's why we are concerned about it. Next, this sulfamethoxazole also displaces bilirubin, and hence it can increase risk of kernicterus. Okay, so it displaces bilirubin from albumin. Okay, and that's why this drug, especially antibiotic, we will not give in neonates. So sulfonamides are PABA analogs which block dihydroteroid synthetase enzyme, decrease folate, causes growth arrest. It is bacteriostatic. But if combined with trimethoprim, it is bactericidal. You have to ensure hydration to prevent crystalluria, and you have to screen for G6PD deficiency. This is very important, or else it will cause hemolysis. Now, drug of choice for nocardia is clotrimazole. Mechanism I have told you, and causes kernicterus also I have told you. So let's go to the questions. PABA analog blocks which enzyme? Dihydroteroid synthase. Next, combination trimethoprim plus sulfamethoxazole. This is bactericidal, okay? This is bactericidal. Uses are UTI, nocardia, toxoplasma. There we use sulfamethoxazole with pyrimethamine, not trimethoprim. We use with pyrimethamine. So PABA analog blocking folate synthesis is the mechanism of action. Sulfasalazine is used in inflammatory bowel disease treatment. Increased INR occurs with what? Occurs with the warfarin. Okay, warfarin when used with the chlortrimoxazole or sulfamethoxazole trimethoprim, it can cause CYP inhibition and cause increased INR. Drug of choice for nocardia is very good, sulfamethoxazole and trimethoprim combination. Okay, causes sulfonamide. What it causes? It causes hemolysis in G6PD individuals. Okay, fine. So we'll go to next. That is very important. Classification of antifungals. I'll tell you in pharmacology, the most important repeated topic is antifungals. So that's why we need to go in detail. Okay. So this is just an overview of antifungals, and in this we'll discuss azole antifungals. Okay. We'll come to other antifungals also. So basically, this is fungal cell wall. Okay. Important component of this fungal cell wall is this ergosterol synthesis. Okay. So this is plant cholesterol, ergosterol. So the precursor is lanosterol, and this lanosterol with various enzymes is converted into ergosterol. One of the enzyme is this 14 alpha demethylase, and inhibitor of this enzyme, this pathway, 14 alpha demethylase. Remember 14 alpha demethylase, A for alpha, A for azoles. This enzyme inhibition causes is the mechanism of action of azole antifungals. Okay. So now ergosterol doesn't get synthesized, as a result of which fungal cell wall doesn't form properly, and as a result we have fungal cell membrane damage and leak and death. Okay. So it blocks ergosterol synthesis via inhibition of this 14 alpha demethylase, causes membrane leak. So under azoles we have three main examples. One is fluconazole, ketoconazole, itraconazole and voriconazole. Okay. So all azoles. What is the use? Again, candidiasis, aspergillosis, all these things. But one thing you'll remember, Cryptococcus in CSF, we use azoles. Azoles are the drug of choice. One major side effect is hepatotoxicity. I myself have seen 3 to 4 cases of fluconazole induced toxicity. Okay, it is very common. Gynecomastia occurs with ketoconazole. QT interval prolongation occurs with voriconazole. That's why I have given this image. Okay, say V for voriconazole. Okay, and then there are CYP interaction. This is inhibitor. Okay, so that will cause toxicity of other drugs. Now, remember, never combine this with statins and terfenamide, because it can cause QT interval prolongation again. Which one? Azoles. Avoid ketoconazole in adrenal sufficiency. This is because ketoconazole decreases production of corticosteroids. Okay, this is also the reason why ketoconazole is also used to treat Cushing's disease, Cushing syndrome. It will cause enzyme inhibition. That's why it can cause warfarin INR to increase. Okay, now. For CSF, the best penetration is via fluconazole. So fluconazole becomes drug of choice for CSF cryptococcuses and CSF fungal infection. Fluconazole. Fluconazole is also widely used antifungal. Okay. Next, intraconazole. It is used for blastomycosis and histoplasmosis, mainly for lung, ITRA. Okay. And voriconazole we'll use for fungal keratitis. Next, this everything I have already monitored. So there's one thing that you need to monitor is LFTs, because it can cause hepatotoxicity. And second is with voriconazole, you have QT interval prolongation. So what is the drug of choice for cryptococcal meningitis? Yes, fluconazole. Mechanism of action, 14 alpha demethylase inhibition. And which can cause gynecomastia? Yes, it is ketoconazole. So now we'll go through the MCQs. Inhibits ergosterol formation by blocking which enzyme? 14 alpha demethylase. Now I think if I write NEETpg, I'll also get above 150 correct because I have studied so much. QT prolongation can also occur with which? Voriconazole. DASH has best CSF penetration. Yes, fluconazole. Blastomycosis, histoplasmosis, what causes? Which is used to treat? Yes, itraconazole. Visual disturbances, photophobia and all. Basically, it is fungal keratitis. It is by voriconazole. CYP inhibition causes increased warfarin toxicity. Drug of choice for cryptococcal meningitis is again fluconazole. Mechanism is 14 alpha demethylase inhibition. Drug causing gynecomastia is ketoconazole. Okay, so we'll move on to next category of drugs that are overall view of antifungals. Okay, we just saw azole group. Now we'll see all groups. So in this, you will see that this 14 alpha demethylase was basically for azoles. We saw already. Okay. Next is I'll just change the color of the ink. Okay, I think it's not visible. Yes. So this was for azole. So this we have already seen. Now there are some other mechanisms through which drugs will act. So remember, take a screenshot of this because this is a very important topic. Okay, very important. So allyl amines are the group of drugs. Example is terbinafine, which will inhibit this synthesis of this squalene epoxidase. So inhibitor of squalene epoxidase is what? Terbinafine. How to remember? See here. Yes, T. So squalene terbinafine. Sorry, squalene terbinafine. Okay, that is how we remember. Azoles and 14 alpha demethylase will remember anyhow. Okay. Next, see, there are something called as polyenes which cause pore formation in the cell wall. Okay, cell membrane. These are basically amphotericin B, polyenes. So ampho, P, polyenes and pore formation. So their job is to create pores in the cell membrane. Okay. Next, there is something called as beta glucan synthesis defect, which say beta glucan is for cell wall. Okay. The whatever outer covering is there, that is cell wall. What is inside, that is plasma membrane. Polyenes act on this plasma membrane. Azoles, whatever cell synthesis occurs on, that is plasma membrane. But this this beta glucan synthesis defects are there, no? That is basically echinocandins. So these are basically on the cell wall. Okay. Next, you have antimetabolites, that is which are in which resembles this 5-fluorouracil. Okay, flucytosine. They inhibit DNA. They act inside that is they are basically nuclear. Okay. So these are the various mechanisms we have. We'll see again. Polyenes, I told you, P for pore. Okay, so they directly bind to ergosterol and they cause pores. Okay, so we have two categories, amphotericin B and nystatin. Azoles, I told you, they block ergosterol synthesis via inhibiting 14-alpha demethylase. Now, beta glucan synthase on cell wall. This is cell wall, it is not cell membrane. On cell wall is the which category of drug? Echinocandin. So basically, it is candin. So caspofungins. Okay. Next, allyl amines. That is, I told you, it blocks squalene. So ST, that is terbinafine. Okay. So example of this is terbinafine. Okay. And last we have antimetabolites, that is flucytosine, which gets converted into 5-fluorouracil and it will inhibit DNA synthesis. Now, which are the common questions that are asked? One is amphotericin B is known to cause nephrotoxicity. That's why we never combine amphotericin B with loop diuretics. One is because it is nephrotoxic. Loop diuretics also can cause nephrotoxicity. Second is both can cause fatal hypokalemia. I have seen many cases actually where amphotericin B was given and it went into fatal hypokalemia. Like potassium I have seen gone as low as 1.9. I have seen 1.9, 1.8 also, where amphotericin B had caused so much damage that it caused hypokalemia of 1.8 and 1.9. Okay, so it causes fatal hypokalemia. Next, azoles are enzyme inhibitors. So if you give azoles, then it can cause enzyme inhibition and cause warfarin INR to increase. So this is also one interaction you should remember. Second is if you give only flucytosine, there will be rapid development of resistance. So we never give only flucytosine. Okay. So what is the recommended combination to prevent resistance? We give flucytosine plus amphotericin B. Echinocandins, caspofunginol, we give IV only. And terbinafine has, they concentrate in the nail, so it is used in case of tinea infections. Okay. So beta glucan target is cell wall. Cell wall is caspofungin, which are nothing but echinocandins. DNA synthesis block is flucytosine. Drug of choice for oncomycin is terbinafine. Okay. So we'll go to the questions. Polyenes, they cause pore formation. Which are they? Yes, very good. They are nothing but amphotericin B and nystatin. Echinocandins, yes, they are nothing but caspofungin. They cause cell wall inhibition by causing beta glucan synthesis inhibition. Allyl amines inhibit dash. They inhibit squalene. Yes, S and T, squalene epoxidase. Example is T. What is T? Terbinafine. Flucytosine is always combined with dash. It is combined with amphotericin B to prevent resistance. Dash concentrates in nails. Terbinafine. Terbinafine concentrate in nails. Amphotericin B plus loop diuretics, it can cause nephrotoxicity. And one more is hypokalemia. It will be resistant hypokalemia. Okay. Beta glucan target is what? It is beta glucan target is cell wall. That is beta glucan synthesis. Okay. Cell wall formation will be inhibited. So this is about antifungals. Now we'll go to anti-tuberculosis drugs. Now in anti-tuberculosis, I know some things will repeat, but again, these are very, very, very important. Okay. So we'll go through the, okay, we have a common diagram for all the three. So we'll finish the diagram and then we'll come. Okay. So, you know, basically for intensive phase, we have 4 drugs. So that is rifampicin, isoniazid, pyrazinamide and ethambutol. So our main focus is on these 4 drugs only. What is the mechanism of action? See, first rifampicin. Everything is given in this same image. So take screenshot or buy this PDF. Rifampicin, it inhibits RNA polymerase. See here, it blocks RNA polymerase. So RNA synthesis doesn't happen. Second is this isoniazid. Isoniazid inhibits mycolic acid synthesis. So that basically isoniazid inhibits formation of this cell wall. Okay, cell wall formation is inhibited. It's not inside the enzyme, it is outside. Okay, it's not inside the cell, it's on the cell. Cell wall defect. Okay. Pyrazinamide actually it disrupts metabolism. Okay, so basically it decreases membrane pH and it disrupts metabolism. So basically it acts in the cytoplasm. And fourth, ethambutol, it blocks arabinosyl transferase, which again causes cell defect or cell wall. So we have 2 drugs which causes cell wall defect in among first line drugs for anti-TB. That is, one is isoniazid and second is ethambutol. Okay, so we use combination. One is to prevent resistance and to give much more advantage because TB is such a bacteria which is very resistant to killing. Okay, so which are these side effects are for which? Tell me. Orange urine, hepatitis. It causes induction of CYP enzymes. Yes, this is rifampicin. What causes hepatotoxicity and peripheral neuropathy because of pyridoxine deficiency? Yes, this is isoniazid. What causes hepatotoxicity and hyperuricemia? Yes, this is pyrazinamide. And what causes optic neuritis, red-green color blindness? This is ethambutol. Remember, this hepatotoxicity because of this anti-TB drugs, especially rifampicin, pyrazinamide, not rifampicin, pyrazinamide and isoniazid is so rampant. If we start anti-tubercular drug when I was doing my residency, out of 10 people, some 4 or 5 will develop this ATT-induced hepatitis. It was so common, okay? Next, what is the drug of choice for latent TB? Latent TB we use isoniazid, okay? Isoniazid. What is latent TB? Latent TB means patient has TB infection, but symptoms are not there, okay? Like the bacteria is there within, but it is not exhibiting any symptoms, okay? So that is known as latent TB. And what is the first line treatment is? This is 4 a day, okay? So we'll go through few important things. That is, one is ethambutol causes red-green color blindness. That's why this red and green here. Okay. Second is INH plus phenytoin. What will happen is phenytoin is an enzyme inhibitor. So it will cause INH toxicity. INH is an enzyme inhibitor. So what it will do? It will cause phenytoin toxicity. Okay. So that is what the importance of enzyme inducers and inhibitors are. Rifampicin again is an enzyme inducer. So it decreases OCP efficacy. Ethionamide is a second line drug which is used for treat TB, okay. Cycloserine causes psychosis. This is also second line treatment which we use. And clofazimine causes leprosy pigmentation. All these 3 questions are asked in INICET. So next, initial we'll diagnose TB. Then once we start your drugs, we'll monitor LFTs for hepatotoxicity. Then we'll monitor vision also for ethambutol. So these 3 things I have already discussed. I think we have done everything. We'll go through questions. There are 3 topics specifically dedicated to anti-TB because many topics, all these topics are very important. Okay, we see in day-to-day basis. So rifampicin causes what? It causes orange urine. Okay. Isoniazid inhibits what synthesis? Mycolic acid synthesis. Next, pyrazinamide is hepatotoxic and it causes hyperuricemia. Remember, hyperuricemia. Ethambutol causes what? It blocks which enzyme? It blocks arabinosyl transferase. So it will cause cell wall defect. Okay, arabinosyl transferase causing cell wall defect. Second analog of INH is, say basically INH is its analog which is used as second line drug. It is nothing but ethionamide. Cycloserine causes which side effect which is asked for exam? Psychosis. Leprosy pigmentation, yes, very good. Clofazimine is the drug which causes pigmentation in case of leprosy. Next, drug of choice for latent TB is INH. That's why we give INH prophylaxis. Remember, INH prophylaxis you would have heard, no? So that is why we give INH prophylaxis. Protein synthesis inhibitor, yes, streptomycin. Okay, so streptomycin is basically, it basically inhibits 30S subunit. Okay, so 30S subunit of ribosome is inhibited. So it is 30S aminoglycoside. Which is one more 30S you came across? Yes, very good. Yes, remember which another 30S you came across? Yes, it's tetracycline. Tetracycline was also inhibiting tRNA in tetra for tRNA in 30S subunit. One more was 50S. 50S was for macrolides. Okay. All are hepatotoxic except rifampicin. Sorry, ethambutol. Sorry, ethambutol. Even rifampicin is also hepatotoxic. Next, even streptomycin is also not, okay. Streptomycin is also not hepatotoxic. INH neuropathy without what? B6. I have seen 1 or 2 cases of INH toxicity neuropathy. That was because someone who prescribed ATT didn't start pyridoxine. Ethambutol, optic neuritis. Which type? Red-green color blindness. DASH causes less CYP induction. Okay, when you give for HIV regimen, okay, which causes less CYP induction? It is rifampicin. So rifampicin causes CYP induction. So we use something known as rifabutin. Okay. For rifabutin we use when a person along with the problem is if a person has both TB and HIV, what will happen is this rifampicin, it will cause enzyme induction and it will decrease the efficacy of all HIV drugs. So instead of giving rifampicin, we'll use rifabutin. So positive ANA, lupus-like reaction is caused by which drug? It is INH. Yes, so we have completed anti-TB. Now we'll go to anti-leprosy. Okay, we have almost the same things only to be discussed. See, rifampicin is again used here. I will not discuss again. Dapsone is one drug which is used. Now it can cause, it is similar to the sulfa drugs. Okay, it can cause hemolysis and it will cause methemoglobinemia also. Third is clofazimine, which causes red-brown pigmentation. Okay, so which we have discussed already. So which is this drug? Rifampicin. This one G6PD, dapsone, and this is clofazimine. Okay. So G6PD, avoid dapsone. Pigmentation which is caused by clofazimine is irreversible. Okay. Sulfone syndrome. See, when you start this dapsone, you can get something known as sulfone syndrome. For that, you'll have to stop the drug immediately. So dapsone will cause sulfone syndrome. Clofazimine has anti-inflammatory property also. Hence, it is used in erythema nodosum leprosum. Okay, that is basically a leprosy reaction. Okay, so it has anti-inflammatory. That's why we use it. Third is rifampicin induces CYP. Again, it causes OCP deficiency. I think this has repeated so many times about rifampicin and enzyme inducers. Now we'll never forget. Okay, so screen for G6PD before starting dapsone. Same thing we did for sulfur drugs also, that is sulfonamides. Monitor LFT because of hepatitis risk, and third is monitor skin and GA symptoms for clofazimine. Okay, I think I have discussed everything. We'll go to the questions. What causes hemolysis and methemoglobinemia? Yes, very good. It is dapsone. And what causes red-brown skin pigmentation? It is clofazimine, which is irreversible. Dapsone causes what syndrome? Sulfone syndrome. And what happens in sulfone syndrome? You'll have fever, rash, and lymphadenopathy. Yes. So next is we'll be discussing monoclonal antibodies. Okay, so monoclonal antibodies are specific target against certain receptors. Okay, so those monoclonal antibodies which are derived from mouse, okay, which has highest immunogenicity, that is because they are not human, no, they are mouse, so they are known as OMABs. Okay, OMAB, which are mixed from human and mice, they are known as XIMIPs. So X is for cross, which means it is a hybrid. Next, which are humanized, they are known as ZUMABs. Okay, and UMAB is the lowest immunogenicity, which is completely human. Here we'll have some other species also crossed, but here we have only human, purely human. Okay, so OMAB is fully mouse, chimeric is X, that is XIMIP, humanized is ZUMAB, and fully human is UMAB. Okay, so there shouldn't be any confusion. Now, how do this act? They identify the antigen. They'll have antibody binding, okay, to specific receptor. Then it will cause immune modulation, and it will cause destruction of the cell, and hence it will have therapeutic effect. Examples are like rituximab. Zimab means it is a cross, chimeric. Okay, so it acts on CD20 receptor. Similarly, trastuzumab acts on HER2 receptors. Okay, and TNF alpha is infliximab. Okay, TNF alpha inhibitor. So that is XI. So it is chimeric. So there are multiple uses as biologics in many diseases we'll use. Okay, so I think that is it about it. There is nothing much you want to know. For this specifically, you refer recent update section. Okay, recent update section under your specific coaching app platforms, because this recent updates will be very useful for you to about monoclonal antibodies that can be asked in the exams. Okay, I can't discuss everything here because many new recent updates will come. So go to its respective coaching app platform and go through recent updates of monoclonal antibodies. Next, we have corticosteroids, miscellaneous category of drug, which is used as immunomodulator also. So what is the mechanism of action of corticosteroid? Corticosteroids will act on the nuclear receptor, that is cytosolic glucocorticoid receptor first. It will get combined with the cytoplasmic receptor, then it will go into the nucleus, and then it will cause genetic transcription. Okay, when it is transcribed, it will cause increased anti-inflammatory proteins, and it will decrease cytokines. So basically it is anti-inflammatory. So corticosteroids, they are synthesized from phospholipase A2. So inhibition of this phospholipase A2 will decrease corticosteroid and prostaglandin synthesis. Okay, so what are their functions? Anti-inflammatory, anti-allergic, gluconeogenic, immunosuppressive. All positive effects are given by these glucocorticoids. So they are used in wide variety of diseases. One is in asthma because there is more inflammation, autoimmune diseases, again inflammation, transplant to suppress inflammation, and adrenal sufficiency as a supplement. Now, rare facts are that this annexin-1 increase, this annexin-1 molecule, its increase can cause decreased phospholipase A2 and can decrease production of corticosteroid. So just remember this much: if there is increased annexin-1, then it will negatively inhibit phospholipase A2. Okay, just remember that much. Nothing else is required. Also, this corticosteroids, it will cause margination of neutrophils. That means neutrophils which are there in the peripheral part of the blood vessels, they will get migrated to the it causes demargination. Sorry, margination is when they attach to the endothelial cell wall, WBCs. So this is prevented, as a result of which what will happen is in the blood you will get increased neutrophil levels. Okay, so one of the reasons why after starting corticosteroids there will be increased WBCs, increased neutrophils, and many times clinicians will be worried like what is the cause. Basically cause is it's normal phenomenon of corticosteroids. Okay, so next, long-term use of corticosteroids will cause adrenal suppression, so it shouldn't be abruptly withdrawn. Okay, it can cause Addisonian crisis also. It will be very dangerous, life-threatening situation. So always whenever you give corticosteroids, you should always taper it slowly over days. Okay, you should reduce the dose and then you have to taper it, or else it will cause acute adrenal crisis. It is contraindicated in systemic fungal infection, very important, because it can cause fatal fungal infections. Next, Cushingoid features are related to adverse effects. Osteoporosis can also occur, hyperglycemia, increased infection risk. So all these are related to corticosteroid side effects, and also you'll have gastritis and GRD. Okay, GRD, yes. So next, I think all this I have give morning dose. Okay, that is because corticosteroid the circadian rhythm will be increased in the morning. Okay, so it will have diurnal rhythm, so we always prefer morning dose. Next, you will taper it slowly if it is a long-term therapy, and you will give calcium and vitamin D supplementation to counteract for bone loss. Okay, I think I have explained everything. Okay, so let's go to the questions. Yes, rapid effects inhibits what? It inhibits dash causes decreased prostaglandin and leukotrienes. It inhibits phospholipase A2. Since phospholipase A2, okay, it is involved in the synthesis of this arachidonic acid. Okay, arachidonic acid that will in turn lead to formation of so phospholipase A2, actually this is the cell wall, okay, where phospholipids are present. Phospholipase A2 breaks this to form arachidonic acid, and this arachidonic acid will further be broken down by COX enzyme. This is inhibited by NSAIDs, because this arachidonic acid will lead to formation of prostaglandins, leukotrienes and all. Okay, so this is basic pathway. So steroids act at this part, okay, the one before NSAID. NSAID is cyclooxygenase inhibitor, phospholipase A2 inhibitor is corticosteroids. Increased DASH synthesis inhibits PLA2, that is increased annexin-1 synthesis, okay, annexin-1. Downregulates DASH expression, it downregulates COX-2 expression. So steroids have this side effect also. Causes demargination of neutrophils, leading to what? It causes neutrophilia. Next, abrupt withdrawal causes Addison's crisis or adrenal crisis. Give DASH dose to mimic diurnal variation. We'll always prefer morning dose. One more important thing that can be asked in our exams is the potency. Which corticosteroid is more potent and which is least potent? So remember, most potent is a hydrocortisone. So, sorry, the lowest potency, we'll go from low potency to highest potency. Hydrocort has lowest potency, okay, hydrocort. Then we have prednisone. Then we have prednisolone. Okay, these both, there is minor difference. If you are interested, you just comment in the comment section, I'll tell you the difference. Then we have methylprednisolone, MPS. Then we have Dexa, okay. So if anyone asks you which is the most potent, it is Dexa. What is the meaning of most potent? Which means the same effect, Dexa can cause at very low dose, but hydrocort requires a very high dose to cause the same effect. That is the meaning of potency. This can come as match the following, okay. Yes. Next we have calcineurin inhibitors, which are basically immunomodulators. We have two drugs, one is cyclosporin and one more is tacrolimus, okay. So both act on these mainly T cells and mainly on T cells, okay. So cyclosporin activates this cyclophilin receptor. Tacrolimus acts on this FPK12. Both you don't have to remember. Just remember that they inhibit this calcineurin phosphatase. Okay, they inhibit this calcineurin phosphatase enzyme, which in turn will decrease production of this IL-2. So just remember two things, calcineurin and IL-2. Then after that it decreases IL-2 cytokine, decreases T cell proliferation and everything. So just calcineurin inhibition causing decreased IL-2. This is the only thing that you need to remember. Cyclophilin, FBK12, I don't think it is required. It is used in graft rejection prophylaxis, which means before graft rejection occurs, as a prophylaxis, you give these drugs. It is also used in autoimmune diseases like rheumatoid arthritis and psoriasis. Okay. Now, tacrolimus is more potent than cyclosporin. Both are metabolized by CYP3A4. They are metabolized. Okay, they are not inducers or inhibitors. They are metabolized. So other inducers and inhibitors can cause their levels to vary. It does not affect bone marrow significantly. Okay, that is important. Now, what is the dose limiting adverse effect for both is nephrotoxicity. Remember, nephrotoxicity is the dose limiting effect for both cyclosporin and tacrolimus. Cyclosporin has some itch, that is hypertension, hyperplasia of gum, hirsutism, similar to phenytoin. No? So that's why cyclosporin has side effect profile similar to phenytoin. Tacrolimus is known to cause diabetes and neurotoxicity. Okay, but the cyclosporin side effect is more important. I think I have told you everything. Okay, don't use with NSAIDs concurrently, and use with corticosteroids in case of graft prophylaxis. Okay, rest of the things I think I have already explained. So let's go to the questions. Decreases IL-2, binds to tacrolimus FBPK2, right? Sorry, FKBP12. FKBP12. And it inhibits calcineurin. Tacrolimus is more potent than cyclosporin. What causes gum hyperplasia and hirsutism? Yes, it is cyclosporin. Tacrolimus causes what? Diabetes. That's it, what you need to know. Next we'll go to next topic, that is antidote for common poisoning. Okay, so there is separate chart for this. So basically we have antidote to act on something that causes, okay, it can be an enzyme or it can be direct antagonist activity. Okay, so for opioids we have naloxone. This acts on mu receptor. So mu receptor antagonist is naloxone. We have discussed this in under opioids. For benzodiazepines, again we know that we have flumazenil. Okay, so for benzodiazepines we have flumazenil. Next, for methanol toxicity, okay, we have ethanol. Okay, so the antidote for methanol toxicity is ethanol only. Next, for iron, okay, see here iron we have deferoxamine, okay, which is a chelation agent. For lead we have EDTA or dimercaprol, chelation therapy. Heparin we have protamine sulfate, we have already discussed. Warfarin, vitamin K we have already discussed. Digoxin, digibind we have already discussed. Isoniazid, pyridoxine we have already discussed. Atropine and pralidoxime is for organophosphates. Okay, so this organophosphates, that is for organophosphates we have atropine and pralidoxime. Next, for N-acetylcysteine we have for paracetamol we have N-acetylcysteine, we have already discussed. For ethanol toxicity we have something known as fomepizole. Okay, sorry, for methanol toxicity we have something known as fomepizole also. This fomepizole, it inhibits this alcohol dehydrogenase. Okay, and for methanol toxicity we also can use ethanol also. Okay, next, for cyanide we have thiosulfate. Okay, sodium thiosulfate we'll use for cyanide. Okay, so flumazenil, you should remember that it can cause seizures if it is used in overdose. Atropine alone cannot cause nicotine reversal. Okay, atropine should be used along with trialdeoxide. And next is NSA is most effective if you give within 8 hours of paracetamol poisoning. Methylmethylglobinemia, we use methylene blue. I also gave my own example. Next, for copper toxicity, we use penicillamine, which is also used in Wilson's disease. For beta blocker toxicity, this is very strange. For beta blocker toxicity, we use glucagon. Okay. So I think I have answered everything. Okay. For cyanide, we use hydroxycobalamin and we use sodium thiosulfate. Okay. Yes. So we'll go through questions quickly. Opioids, naloxone, benzodiazepines, that is GABA receptor antagonist, which we use. For benzodiazepine, we use flumazenil. Okay. Next, for methanol toxicity, we use fomepizole, or we can use ethanol also. For what do we use thiosulfate and hydroxycobalamin? Yes, we use it for cyanide toxicity. Because this thiosulfate is there, no, that will combine with the cyanide, causing it leads to sodium thiocyanate, this compound. Okay, so whatever the cyanide ion was there, that combines with sodium and thio, causing sodium thiocyanate because it displaces sulfate. Next, heparin, we use protamine sulfate. Okay. Next, for methylmethylglobinemia, methylene blue. For copper, penicillamine. For beta blocker toxicity, we use, yes, very good, we use glucagon. For NAC, that is N-acetylcysteine, is most effective within 8 hours of ingestion of paracetamol. Drug for paracetamol toxicity is N-acetylcysteine. Next, we are going to see drug causing drug-induced lupus. Okay, do we have an image? Yes, we have an image. So basically what happens is some people are slow acetylators, because of which this drug gets accumulated. So acetylation is basically a drug metabolism step. So drug accumulates, causes autoantigen exposure, which causes antibodies. These antibodies are basically antihistone antibodies. So if you go into SLE, you will see that for drug-induced lupus, it is antihistone antibodies, okay? And that causes drug-induced lupus. Now, what are the most common drugs that you need to remember? One is isoniazid, which we already discussed just a few minutes ago. Then you have hydralazine, which is an antihypertensive. You have procainamide, which is an anti-arrhythmic, and phenytoin, which is anticonvulsant, okay? Now, mechanism of action is like same, like acetylation and same causes, okay? And it will finally lead to antihistone antibodies. So fatal example, do not confuse it with normal SLE. Drug-induced SLE has good prognosis. It is not associated with complement consumption also. So drug-induced lupus doesn't cause renal and CNS involvement, and hence it has good prognosis. Here anti-DSDN is negative, but anti-histone antibodies are positive. Okay, so symptoms resolve after drug withdrawal. So let's go through the questions. Which antiarrhythmic causes drug-induced lupus? Yes, it is procainamide. Procainamide is which class? Class 1. Antihypertensive, which antihypertensive causes? Yes, very good. It is nothing but hydralazine. Hydralazine is a potassium channel opener. Antitubercular drug which causes is INH. Next, DIL, that is drug-induced lupus, lacks which involvement? Renal and CNS. Anti-DSDN negative, but what will be positive? Anti-histone antibody will be positive. Organ spared is CNS and kidney. Okay, we'll go to next topic, that is drugs causing hemolysis in G6PD. So I think by now you know the mechanism. That is basically this drug is an oxidant that requires reactive oxygen, and also along with reactive oxygen species that will cause hemolysis. What happens is this G6PD, no, actually it causes NADPH release. This NADPH counteracts this reactive oxygen species. But what happens in G6PD, you have decreased NADPH due to G6PD deficiency, as a result of which this oxidant drug and this reactive oxygen species causes so much damage to the RBC that it will undergo oxidative injury, hence bodies will occur and it will undergo hemolysis. Okay, so we have come across few drugs which I already told you. One is primaquine in anti-malarial, which is important. Sulfa drug we just now discussed. We also discussed dapsone. We also discussed nitrofurantoin, okay, and aspirin you don't have to remember, only in high doses it causes. Otherwise, you have two antibiotics. This is also an antibiotic, sulfamethoxazole and primaquine, anti-malaria. So that's why very important. This is day-to-day basic knowledge you should have. Before starting primaquine, always check for G6PD levels. We had such a patient, an elder male adolescent around 16 years, who had symptoms of malaria. Someone started him anti-malarials along with primaquine, and he landed up with hemoglobin of 2.2 something, okay, because he underwent intravascular hemolysis. The hemolysis was so severe. Later we did G6PD levels, but you should know there are some clinical indications also. Immediately you can't do. You should do it after 3 months. So then we suspected it was because of G6PD deficiency. We followed him up after 3 months, where his G6PD enzyme levels were very low. So that can be the effect of this G6PD. That's why always do G6PD levels before starting primaquine. Next, G6PD hemolysis can also cause hemoglobinuria, and this hemoglobinuria can also cause acute kidney injury. Okay. Next, there is something called as favism, that is after consumption of fava beans, that hemolysis can occur in G6PD. Also, G6PD deficiency is an excellent recessive disorder, and this G6PD you detect with the deficiency you detect with fluorescent spot test. Okay, I think I have discussed everything. So let's go to the questions. Anti-malarial which causes, very important, is primaquine, because nowadays we rarely use chloroquine. Antibiotics are nitrofurantoin, and one more antibiotic is dapsone, which we discussed in leprosy. Dash is equal to hemolysis after favabins, it is favism. Avoid empiric primaquine without dash screening, G6PD. Mechanism is NADPH deficiency, causes oxidative stress. So next we are going to drugs causing methemoglobinemia, again a very important topic. Yeah, so drugs causing methemoglobinemia. So basically what happens is there will be ferrous iron. Okay, there is some oxidizing drug which causes oxidation. What is oxidation? Oxidation is increasing plus charge on the ions. Okay, that is addition of a proton. Okay, so that's addition of a proton or loss of an electron. So because of which there will be ferric ion formation that leads to methemoglobinemia. Methemoglobinemia, what happens is it doesn't dissociate from hemoglobin. Okay, as a result of which there is cyanosis and decreased oxygen carrying, and there will be cyanosis. Okay, so chocolate brown color of blood will be there, and cyanosis is not reversed by oxygen. We had a patient who came to our emergency who was diagnosed with malaria and started with primaquine. Okay, and this particular girl, what happened was, she was started on chloroquine, not primaquine, chloroquine. And we noted that she was very sick. We thought initially it was complicated malaria because of ERDS and all. Cyanosis won't pick up. Okay, but she had saturation of around 80, 85, and even with 100% NRBM, saturation didn't improve. And then we were like, there could be some other reason, because we are giving 100% O2, something should have improved. We had intubated also. But after that, we just sought to the medications. We found important thing that was chloroquine was given to that patient. And then we did methemoglobinemia levels under ABG, and that was found to be very high. Okay, so that is how we diagnosed an interesting case. Finally, the child recovered after staying in PICU for around, I think 1 week. It took around 1 week. We gave methylene blue, which is actually the antidote for methemoglobinemia. So there are some agents like which we discussed under local anesthesia, especially prilocaine and benzocaine. Okay, these local anesthetics, prilocaine, benzocaine, these causes oxidation. Okay, prilo and benzo. Similarly, nitrates, that is sodium nitrate, amyl nitrate, which are used for angina, they also cause same thing. Okay, including sodium nitroprusside. Then we have leprosy drug, that is dapsone and sulfonamides, which causes oxidative damage. And finally, we have chloroquine, as discussed in my case. So if there is G6PD deficiency, there is very high chance of having methemoglobinemia. Okay, so avoid. Second thing is treatment of choice is methylene blue. So you should avoid methylene blue in G6PD deficiency also. This is another thing. So high levels of methemoglobinemia cause hypoxia, unresponsive to oxygen. That is a very important thing. Okay, hypoxia not responding to oxygen can be only two things in pediatrics mainly. One is it is cyanotic heart disease where it won't improve, and second is methemoglobinemia. So methylene blue will give. Okay, it causes NADPH dependent reduction. It will cause Fe3 plus to go into Fe2 plus. So dapsone causes dose-dependent methemoglobinemia, and there are some congenital forms also due to which there will be NADH reductase deficiency. These are other mechanisms of methemoglobinemia. We'll go to the drugs which cause. Okay, so which antibiotic cause? Yes, one is sulfonamides, and second is sulfonamide, which we had discussed, and second is dapsone. Yes, dapsone. Anti-malarial, which it causes, chloroquine. Okay, treatment is done by NADPH dependent reduction is done by methylene blue. Avoid methylene blue in which deficiency? G6PD deficiency. That's why we do G6PD levels first. Drug causing methemoglobinemia, dapsone, and one more is which we had discussed here. Yes, all these drugs. Okay, about drugs. Yes. So I think you're not going to forget what are the drugs. One is benzocaine. One is one more antibiotic. Anesthetic is prilocaine. Then you have 2 nitrites. You have 2 antibiotics and 1 anti-malarial. So next we have prominent drug interactions. So this is a summary of whatever we have discussed so far. So I told you for drug metabolism, drug level, there can be an inducer drug which causes increased activity of the enzyme, and so that's why the total level of the drug will decrease. And there can be an inhibitor drug which decreases enzyme activity, and hence it can cause drug toxicity. Okay, examples are like ketoconazole is an inhibitor, rifampicin is an inducer. So you see here, CYP induction is done by rifampicin, phenytoin, carbamazepine. See, rifampicin is ATT, I told you. ATT causes, rifampicin causes CYP induction. On the same hand, INH causes enzyme inhibition. Remember it like this. Phenytoin and carbamazepine are sodium channel blockers under what? Antiepileptics. That causes enzyme induction. Okay. Next, phenobarbital is what? GABA potentiator. That is also antiepileptic. That also causes CYP induction. All this causes decreased efficacy of one important drug, that is OCP. Now, next is enzyme inducers, ketoconazole, erythromycin, and cimetidine. All this will cause toxicity of other drugs which are metabolized to CYP3A4. Now, other than this, there can be other drug interactions where some drugs will alter albumin binding site displacement. Okay. So, for example, NSAIDs, when you are giving with warfarin, what they will do, they will displace some other drugs and it can precipitate warfarin toxicity. So, there will be bleeding risk. Next is additive toxicity, which means 1 + 1 = 3. AC inhibitors also cause hyperkalemia. Potassium sparing diuretics preserve potassium, so they also supplement the effect and hence causes fatal hyperkalemia. There can be some opposing effect and hence there won't be any drug interaction at all. For example, beta blocker also you are giving and you are giving beta agonist also, so there is no effect of that. So there are some inducers. So these drug inducers should be avoided in transplant recipients because I told you just now we were discussing cyclosporine. Cyclosporine actually is metabolized by CYP3A4. So cyclosporine effect will decrease if you give these enzyme inducers. So there is no point. Our graft will finally be rejected. Okay. Similarly, serotonergic drugs you don't combine with MAO inhibitors because it can cause serotonin syndrome. Okay. Next, warfarin interactions are fatal. See, there are only few drugs whose interactions are very fatal. Like for example, I told you cyclosporine. Okay, you should be very careful. Second is warfarin, which you should be very careful. Third is like clopidogrel, like omeprazole along with clopidogrel, same enzyme, very careful, which must be very careful. Fourth is theophylline. Okay, theophylline also enzymes levels can be increased, toxicity can occur. Okay. So this is exactly what we were discussing, and see, you can remember these short forms also. We have discussed it earlier also. So enzyme inducers are basically phenytoin, carbamazepine, rifampicin, phenobarbital, grisophulvin, which is an antifungal, and we have smoking and St. John's wort. Under enzyme inhibitors, we have azoles, grapefruit, protease inhibitors, that is HIV. In HIV, we use cimetidine, amiodarone, macrolides, okay, and CCBs. Okay, yes. So additive toxicity of ACE plus potassium sparing diuretics causes what? It causes fatal hyperkalemia. Avoid enzyme inducers in DASH recipients, in graft recipients. Okay, next 80th, last one is regarding warfarin, because warfarin has much interactions and many questions can be asked. Okay, so warfarin basically inhibits an enzyme known as vitamin K epoxidase. What happens is, see, vitamin K is required for carboxylation of coagulant factors 2, 7, 9, 10. Okay, so that is the function of this vitamin K hydroquinone. Okay, so this vitamin K hydroquinone, it will finally undergo gamma carboxylation to form this 2, 7, 9, 10 activated factors and activates other coagulation factors. Now for vitamin K to get activated, it should go through this process, this cycle, where one important step is vitamin K epoxide reductase. Okay, vitamin K epoxide reductase enzyme, and this reduction process is inhibited by warfarin. Okay, that is the mechanism of action of warfarin, and that's why when you give active vitamin K in the blood, IV vitamin K, IM vitamin K, that actually is the antidote of choice. Okay, so important thing is warfarin has delayed mechanism of action because this inhibition will take some time, and second is there will be already activated factors. No, they should also their T-half should also complete half-life. Only then action of warfarin will start. That's why always before you give warfarin, you should always bridge it with the heparin. That is low molecular weight heparin, which is enoxaparin. So for around 5 to 7 days, we have both therapy, and after that, we'll switch completely to warfarin. Now, you can't actually monitor warfarin levels directly. So what we'll do, you will do INR based monitoring, that is PT-INR based. So always we keep a target of 2 to 3. It shouldn't be less than 2 also, and it shouldn't be more than 3 also. If more than 3, then it can cause bleeding. Okay, so coagulation won't happen. So what are the main indications of warfarin? One is in DVT and pulmonary embolism, in atrial fibrillation, stroke prevention, when there is prostatic valves. Wherever thrombosis can occur, there all we give warfarin because it will clot. It is an anticoagulant. It will prevent coagulation. Now, vitamin K, whichever we are administering, it is phytonadione, okay, and this is the antidote for warfarin toxicity. Also, we'll give prothrombin complex concentrate, PCC, okay, this can also cause bleeding reversal. Warfarin is contraindicated in pregnancy because it causes fetal warfarin embryopathy, that is teratogenic bone and CNS defect in the child. So in pregnancy, the drug of choice for any type of thrombosis is what? It is basically low molecular weight heparin. So that's why we bridge heparin and warfarin, okay. Next, what are the drug interactions? So there are some inhibitors which will cause toxicity. That is, it will cause increased warfarin effect, increased INR, and increased bleeding risk. So these are CYP2C9 inhibitors. These drugs are amiodarone, metronidazole, TMP, fluconazole. In this, you will have to remember, one is fluconazole, sulfamethoxazole. These two examples you remember. One more is amiodarone, okay. And CYP2C9 inducers are there. Now this one you will remember anyhow, but here you'll have to remember fluconazole, metronidazole, and amiodarone, okay. So what does inducers do? Inducers will cause decreased warfarin effect and cause decreased thrombosis risk, but yeah, it will cause decreased it will actually promote thrombosis, okay. That is, it will not cause warfarin to show its effect. Now what are the other interactions? From albumin, this NSAIDs and aspirin can displace warfarin, whichever is bound to this albumin, and hence increased free warfarin is there in the blood, hence it can cause increased bleeding. So don't combine NSAIDs, aspirin along with bleeding. You should be very watchful. Second is when you give antibiotics, it will cause killing of gut flora. Now gut flora is a main source of vitamin K production. So what will happen when vitamin K is decreased? Again, warfarin activity will increase, so INR will increase. Third, vitamin K rich foods can also decrease warfarin effect. Okay, so warfarin is such a versatile drug. We use it in many cases. That's why you should know about warfarin. Next, if you give only warfarin without giving heparin, it can cause something known as warfarin skin necrosis. That's why you should bridge along with heparin. Second, if you combine with aspirin and NSAIDs, what can happen? One more effect is one is it can displace warfarin from albumin. Second is it can also aggravate GI bleeding because NSAIDs cause gastric ulcer, aspirin also causes. So that can also precipitate. Third is broad spectrum antibiotics don't give without checking INR because it can what can it do? It will cause decreased gut flora, causing vitamin K levels to decrease. So it is important to know that protein C level will fall first when you give warfarin. Okay, so there will be transient hypercoagulable state, and that is the reason if you start warfarin alone, you will have warfarin skin necrosis. Okay, second is weak core, that is this enzyme polymorphism can also exist. So that's why for some people you will have to do dose alterations also. And third, rifampicin will drastically decrease INR levels within days because it is an enzyme inducer. So you should be very careful regarding vitamin K. Sorry, regarding rifampicin when you are combining with this. Okay, so here we have inducers and inhibitors list. So we'll go through the questions, and with this we'll finish pharmacology also. So decreased warfarin is caused by what? Warfarin effect, rifampicin and carbamazepine, and one more is phenytoin. Okay, next, antibiotics, what it will do? Antibiotics will kill gut flora and it will decrease vitamin K, increasing warfarin effect. Warfarin plus dash causes severe bleeding. Warfarin plus aspirin or NSAID. What causes drastically decreased INR? Rifampicin. Okay, rifampicin. Warfarin causes dash metabolism, leads to inhibition of inhibitors, increased INR, induces decreased INR. So basically, which enzyme pathway warfarin is metabolized via? It is CYP2C9. Okay, CYPC29, I think. Let me go through. Okay, CYP2C9. Yes, correct. Next, warfarin inhibits vitamin K epoxide reductase enzyme. Okay, so vitamin K epoxide reductase enzyme. Next, onset of action is little bit delayed. That's why we bridge it with heparin. That is LMWH or enoxaparin. Next, monitor PTR goal is very important. It should be between 2 to 3. So what happens is if the INR levels are like 4, like you called a patient and his PTINR is 4.1. So what you'll do? You will decrease warfarin dose. If the levels are 1.2, what you'll do? You will increase warfarin dose. Okay, you want to keep it between 2 to 3. Dash falls first, causing a transient hypercoagulable state. Once you start warfarin, it is nothing but protein C. Okay. Next, start alone causes what? It causes warfarin skin necrosis. If you start only warfarin, it can cause warfarin skin necrosis. Check INR dash after initiation, then monthly. Check INR weekly. Weekly you will have to check. Okay. Yes, with this we have combined, we have finished pharmacology. So there are 3 parts in this video. First part we covered general pharmaca. Second we covered systemic pharmacology part 1. And third we covered systemic pharmacology part 2. Total duration which we took was for general pharmacology 1.5 hours. For systemic part 1 we took 3 hours. And for this finally we took around 2 hours. So total we have completed within 6.5 hours. And I guarantee there won't be any other resource which covers within 6.5 hours. Content is also less. Timing also less. But still the content is apt and efficiency is also high because of visual mnemonics. So along with this, what you have to do now? First you have to do PYQs. Remember, first you do PYQs. Okay, PYQs are the most important. Second is you have to go through recent update section under your respective app, and you should see what are the recent updates that are given under pharmacology. Okay, these 2 if you do, I will guarantee that this will be more than enough to crack your pharmac exams. Okay, so all the best. Next subject will be medicine, which we'll be covering. There will be total 171 topics in medicine, and we'll be covering it in superficial so that we finish whole medicine within like 7 to 8 hours. Okay, thank you.